Good morning, everyone, again. This is our second day, and Dr. Barrow will talk about information technology and antimicrobial stewardship program. So,
thank you. Okay, just a question. Do you hear me without the micro? Is it okay without the micro? Yeah? No, you prefer the micro? Yeah. Okay. Okay. Is it better like that? Yeah. Okay. Sorry for my voice. Just got a cold last week, which is a shame for an infectious disease specialist, but yeah, they lied to me. I thought that I will be immunized against every cold, but when I got my diploma, but it was wrong. So first and foremost, I'd like to thank the organizer to invite me for talking about one of my favorite topics. I owe you an apology. I just sent my presentation very late, so it is not in the book, but you will have it. No, you don't have it. You will have it. You will have it. Yes, you will receive it by email. So you will have the full presentation. Don't lose time taking notes when it's written on the screen. You will have the presentation, and it's my fault if I send it too late. The bloody cold. Okay, another thing I want to precise is that I had exchanged email with Jeroen Schroeten which gave you a course lesson yesterday, and he told me that you were very dynamic, very positive mind. So I expect the same from him. So please feel free to interrupt, feel free to disagree, feel free to ask questions, whatever. Please don't be too formal. Okay? Okay. So let's talk about the information technology and how it could be applied to antimicrobial stewardship. And oh, by the way, should have told you, I'm a physician, I'm a clinician. So basically my work is to see patients. Okay, on the side, I do some research and some theoretical research, but my day is probably like your day, just to see patients. And I'm a member of SGAP, so if you want to know more about antimicrobial stewardship, we could have talk and we've got course on your own also. So information technology. What is the problem? So let's start with talking about infectious disease. Infectious diseases are difficult. The diagnoses are difficult, and of course, sometimes when you do mistakes, it's very costly from a human point of view, on every point of view. Let's just think about what is fever. Fever could have multiple causes. It could be because of a bacterial infection, so in theory it would request antibiotics, but it could be from viral origin, mild. It could be cancer, it could be embolism, and at the end, it's just fever. So, it's difficult. My favorite part is how, as a doctor, can I say if a patient is cured? Have you ever think about the definition of being cured in infection? The cure of a patient may be cured if no relapse occurs in absence of antibiotics after a certain duration. If you think about chronic osteomyelitis, the certain duration could be months. So we are not even able to say easily when it's cured. You know, one of my friends is an orthopedist. He told me, yes, you know, my job is easy. When it's broken, I can see it. When it's not broken anymore, I can see it. Very simple. Of course, there's some things to do in between, but it's simple. For us, it's difficult. We don't know when, why, and what to do. In other words, we don't know very much, so we need help. On the other hand, you know that the information technology revolution occurred. You heard about a thing called internet, social networks. You probably have smartphone. And it happened all in the 20, 30 last years. And it infiltrated our lives in every point. Not so much, not in the same proportion in the healthcare environment. For numerous reasons. First, because hospital and healthcare is a conservative environment. And of course, there is a lot of concern about data, patient privacy, and so on. But there's a lot of things happening in the rest of the world. So maybe we should pay attention and see how we could use it for our own usage in the hospital or in the primary care. Of course, you know what kind of problem we have to face. There's more and more bugs, resistant bugs, and the resistance is on the rise, and it's probably not going to change soon. There is no new antibiotics, so we have to do what we have to do with what we have. We've got limited option. Basically, if you want to summarize antimicrobial stewardship, you've got two kinds of strategy. The restrictive strategies, you have forms, you have restricted indication, you have antimicrobial approval system. If you want to prescribe this antibiotic, you need an approval, etc. Or you've got another kind of strategy, persuasive strategy. You publish guidelines, clinical guidelines, you explain pathways, you do post-prescription reviews. Both have advantages and problems, but it works. It depends of the environment. But in both cases, you need information. Information is needed to be able to do the right diagnostics, to assess the likely pathogen. What is the significance of an isolate? Okay, you've got bacteria, you've got E. coli in a urine sample. What does it mean? Is it an infection? Is it a colonization? So we need a lot of information. If you only have the urine sample, it's not enough. We need more information about clinical information, biological information, etc. You need information on the susceptibility or about the pathogen usually found in your setting. You need information to select the right antimicrobial, the dose and the right dose, the right duration, to be able to assess the drug interaction, so potential adverse effect. And also, once you've done all that, you want to control and to measure, in order to control, the antibiotic use. If you don't have this information, it will be very difficult. And if you don't have this information, not only because you don't have the right informatic tools, it will be difficult to make antimicrobial stewardship. So we need information. What kind of tools we have? Let's put them in your view very shortly. We've got electronic health records. Basically, it's a patient file on the computer. Nothing very fancy. In the literature, you can find other terms such electronic patient record, electronic medical record. It's more or less the same. Not exactly, but let's say the same. So it's a patient file on the computer. It's a good basis for computer decision support system, but it's not mandatory. If you just have patient file, you will be able to do stewardship, but you will need help. You need people with access to the right databases. So it's a good start. Basically, to put it simply, it's a very efficient way to put everything about a patient in the same place. You know, you don't have to have the file on the patient on the end, to phone to the microbiology, to the microbiological lab to know about the sample, to phone about the pharmacy. It's a way to put everything in the same place. So the concept is simple. Of course, according to your system, you may have option with antimicrobial stewardship modules, depending on the system, but it's basically a patient file on the computer with everything related about this patient on the same place. Clinical decision support system is a step further. It's a process centralizing patient data from different systems, microbiology, radiology, pharmacy. And through this system, you should be able to do prescription. So the idea is to enhance, to improve the prescription quality, but you could do many more things. At the minimum, it's an electronic health record with access to the guidelines and with access to the prescription module. So there is numerous systems available. Some hospitals, some institutions develop their own system. You've got commercial system available, tons, literally tons of them. I just put two examples. which have good reputation, antibiotic assistant and ABX alert. So this is the print screen from ABX alert. So here you can see. Okay, you've got you can see the patient, you can see metadata, data from audit. You can focus on different kind of alarm. Patient with a mismatch between the bug and the drug. Patient with adverse effect. You can focus on a particular patient. Of course, it's not a patient. You've got the alarm. You've got the infection, the bugs, the QT review. You've got what's therapy, treatment, blah blah blah. List of medication. Computer decision support system. You've got everything in the same place. You've got guidelines in the same place. You could put notes. Every doctor involved in this patient would be able to put a word.
Excuse me, sir. Yeah? Is it possible to...
Sure, it should be possible. Maybe it's... You've got a button over there, or you have to do it manually? No? Thank you. Oh. Thank you. It's okay with me. Okay, so far for the computer decision support system. Of course, you've got other tools. You've got your smartphone. Because with your smartphone, you may have access to guides from your hospital, to guidelines. You could use in-house developed app, or you could use commercial app. The most famous are the Stanford guys, the John Hopkins ABX. The problem with the commercial apps is that there's a US bias. So I don't know if you ever try to pay attention to look at the Stanford guide. Really? I don't know for you, but for me it's irrelevant for my practice because it's definitely not the same guidelines as in France. So sometimes it's useful, but most of the time I'm not going to prescribe these antibiotics because it's not very useful. It's made for the US. But some studies show that general doctor prefer apps than the web version. What I would recommend in this case is all to favor in-house app because that could be framed specifically, designed specifically for your needs and for your guidelines. And I wanted to put in under the light the microguide app. It's based in UK, and the interesting part is that it provides a framework, but you can put the guideline you want. You can design it according to your need. So I think it's a very interesting one. I think I've got. Yeah, so this is an app for a smartphone. Don't ask me if it's for Android or Apple. I don't know. I think I think it's available for both. And they provide the framework and they provide the minimum. There are some guidelines, but you can change the guideline according to what is used in your hospital. So the name is Microguide. And you can have it for you. You can for yourself. Yes. What?
Curtains down.
Yes, the curtains are down.
The same way to put it down.
You can ask your hospital to pay for it for the whole hospital. So definitely interesting, an interesting option. But you could use smartphone for something else. Basically, smartphones are phones, so you should be able to communicate. You know this app called WhatsApp. You know, it's quite useful when you travel and you want to use voice over IP. There's two apps I found, funded by doctor, in order, basically the aim at the beginning was to make transmission in a secure way. You know when it's Friday evening and you want to give instruction to your colleague who will be at the hospital during the weekend. So usually I'm still doing that. I use paper, which is a poor way to communicate, and I agree. But sometimes the paper is lost. Sometimes they phone me because they think I am on duty, and in fact I am not. Thanks to this app, TeamDoc and CELO, they were able to show who is on duty clearly, and to put some instruction for certain patients. Okay, don't forget to check the urine sample for this patient, and so on. So I put in first position TeamDoc, but it's in French, so it's probably not very useful for you. But I felt I had to show it. But probably what would be much more useful would be CELO. So it's I think the best definition is it's a WhatsApp for doctors. It's secured. It's designed to be secured, so you can use it for transmitting medical information. It's made for that with a level of security dedicated for that, so it's not a problem. So data privacy and data sharing is not a problem with that. So this is TeamDoc. So it's in French. So, but I will on CELO. Free secure messaging app for medical team player, and you can message, you can put some image, you can ask, you can seek for advice. If you've got a friend with a radiologist, you can send, you know, the picture of the CT chest. You can put some, I like this, you know, anonymized image and do hours. You can do that just on your smartphone, and so the radiologist can give information. Okay, pay attention to that. CELO. Here's one. So, what is the use for information technology in antimicrobial stewardship? I just made a long list. So first thing first, the use should be to alert the AMS team of patient-prescribed antimicrobials in order to support intervention and feedback. What we do in antimicrobial stewardship, we just try to improve the way antimicrobials are prescribed. So we need alert to tell us, okay, here there is this kind of situation, maybe there's an improvement, a potential improvement. Of course, we need for that to identify patient. And the first thing we would like to identify patient with a prolonged antimicrobial treatment, so to see if we can do something. Of course, to identify infected patient, infected syndrome, so we could set up an intervention. We like to help the prescriber with a decision support system according to guidelines and local guidelines. Okay? My situation in France, in Poitiers, is probably very different from your situation, and you shouldn't follow my way of prescribing if your bugs are completely different. Of course, you should be able to take into account allergies, interaction, and so on. Sometimes when you've got very expensive drugs, you want to put in place a restriction of the access for this drug, and so the doctor who want to prescribe, you know, antifungal, by example, would need to fill in a form in order to ask the authorization to be able to, in order to have the ability to use some antimicrobial, some antifungal. Of course, once you've done that, you want to assess, you want to have a feedback, and information technology, you should be able to give you a feedback of what has been done in order to improve the system, in order to improve the prescription. So if you want to improve, you need to measure. So it should be able to do it with just 2 clicks instead of reviewing all the file of the patient. No. Another useful tool is to identify mismatch between an organism and a treatment. With an alert, we'll tell you, okay, there's a problem, because you can't be everywhere in the hospital. You should be able to use the system to implement guidelines and to document. You should also be able to document what you are doing as an antimicrobial stewardship team, because of course this system usually are not free, and even if you don't use the system, your position is not free. I hope so. So if you want to justify the cost of your team, your system, and so on, you should be able to put under the light that it is cost effective. And I can tell you it is cost effective. There have been studies for that. But you need to show it to the head of your hospital. And this system can show you if it's cost effective. It's very useful. So in another word, it will be a useful way to save your position. So what is a system? Okay, you've got data from the pathology, the pharmacy, the microbiology, the radiology. You've got in the center the electronic healthcare records. For some time you can set an antimicrobial approval system. You can manage electronically the prescription. You've got a surveillance system to have alert when there is a problem. And on your own, you've got your mobile application with the calculator to calculate the dose, if you have overweight patient, access to guidelines and so on. Okay, what are the barriers? You have an idea? Yeah, cost. The main barrier is cost. Cost for implementation and cost for maintenance. It's not free. So, when you want to implement an information technology system, basically, usually you want to implement a computer decision support system, you need first to determine your goals, to measure what is the problem, to measure what you're going to do, to measure what you've done, and to demonstrate that it's cost effective. So, you will be able to justify the cost. Another barrier is when the head of your hospital are a very poor manager and they don't want to change. And we can understand that change is difficult, it takes time, it's tiring, it's boring. So again, you need, when you want to implement a system, to show what are the benefits. Because we don't want to change just for the sake of change. We might want to change, we might agree to change if we think there is a benefit. And the benefit should be consequential. Another problem, it's a bit technical, is what informaticians call data silos. Basically, it's a database closed in a closed system without easy access to it. Let's have an example. If you're a pharmacy, they've got a database in one computer in the pharmacy where they put everything about prescription. If you want to access to this data, you need to go on your feet to the pharmacy to put a USB stick into the computer and to access the data. It's very inefficient. So in the past and now, still now, there's a lot of database in the hospital completely separated. And they're not communicating between themselves. There's a pharmacy, there is a lab, there is the clinical ward, and so on. So the first thing is to be able to make this system to communicate, because if they don't communicate, you will have data duplication, therefore you will have inconsistency between data, and you will spend times, days, weeks, months, years to find the inconsistency. That's a huge barrier. That's why you need a system with access to all the database, something centralized. Of course, there is a problem of data security and legislation. So, by chance in Europe, the laws are a little bit better than in North America, but still it's a problem as many systems are US based. So with a concept of data privacy very different compared to Europe. So you need to find the right system and something robust and something validated. Don't try to build it on your own. So finally, this is very common barriers. Sorry for the typo. It's very, very common when you want to implement change. Okay. I review, I said, electronic record system, smartphones, computer decision support system, but it's not only these three. There's also the social medias to Twitter, Facebook, YouTube. And you can use that because it's a very useful way to provide education for trainees. I just learned that this video will be on YouTube. Probably not the best video on YouTube, but still. And it's very useful to use social media, in particular for trainees, because trainees work a lot. They are not so easily able to reach because they spend a lot of time working, but they're very used to social media. So it's a very fine way to reach them. To date, there is no study on is it efficient to use social media to provide education, but it has been proven successful in other fields rather than antimicrobial, so it should work. If it works for many fields in medicine, it should work for antimicrobial. I couldn't find a study assessing the efficiency, but I think it's an interesting way. It's a way so you can disseminate articles, information, you can put quizzes, you can chat over problems, so it should be used. But when you want to use social media, there's a few things you should take care. If you want to start a campaign on social media, you need to keep it active. So it takes a lot of time. It's not something you spend just 5 minutes on it. Keep it active because if it's not regularly updated, people won't return. Keep it interesting, of course. Ensure universal access. Everybody should be able to connect to it. And so choose the right media because sometimes in some hospitals you can't access to all the platforms. If you use multiple platforms, be sure that your activity is aligned. There's the same message according to YouTube, Twitter, Facebook, and so on. You should find a different message according to the platform. But don't use it just for social media. Just integrate the social media with traditional media. Of course, be careful about privacy of data, patient confidentiality. It's very easy to put a radio with a name, and it's a very, very stupid mistake. Social media are useful, but they are not dedicated to ask or to give specific advice for patients because it's too short information in short. Don't use it. There is a particular system dedicated to that, but social media are not made for that, for giving specific advice. And of course, if you find some biased information or mistakes, don't spread it. Don't retweet. Do not retweet. In addition of social media, you can find some resources on the web, notably courses. An easiest way to find courses. And you probably know a lot about massive online open courses. It's a very useful way to gain information. And the interesting part with MOOC compared to a traditional course is that you can have feedback. You can have immediate feedback on your course. So let's take 1 minute digression. If you think the way I'm teaching, I'm giving a lesson at the moment. If you think, do you remember a very old painting from the Middle Age century where usually it was monk, there was a scholar here with a big book reading the Bible or something else, and small monks trying to learn something. It's funny because finally, over centuries, the way to teach didn't change so much. There is a wise guy, so-called competent expert, and there is the people listening. Some are tired, some are sleeping, and it has been the same for years, for centuries, centuries. But for the last 10 years, there is this massive online open courses. And why is it interesting? The thing is that there is an immediate feedback. You can see, thanks to the technology, that if people are going to watch your video from the beginning to the end or make pauses, if you realize that everybody make a pause on the same part of your video, it's probably that at this part of the video there's a problem. Maybe what you explained was not so easy, was not so well explained. So you've got immediate feedback. And I think for a teacher, it's very interesting. And the ways of MOOC, it started with the Khan Academy. And I think it's Samir Khan. This guy was a broker. And so he made a lot of money, and he was really good at science. And he had a nephew on the other side of the US, and the nephew he was in college, and no, not even college, maybe in college, and he had problem to understand basic mathematics. And so through the video over the internet, he asked Samir Khan, who was a broker but very good at science, a very good, strong background in science. Okay, can you explain me integral things in maths? And so what did Samir Khan? He recorded a video, okay, about basic mathematics, about the question, and he sent it to the nephew. And the feedback was, oh, you know, uncle, I like your video. And the good thing is that first I can ask with the video, I can review it over and over, and you're not going to get mad. When I'm tired, I can put a pause and get a coca and get a beer in the fridge, and I can use it where I want it. And it was the trigger to develop the Khan Academy, which I recommend if you are interested in science, mathematics, and so on. So that's why, for the last 10 years, 15 years, I think that there's a massive, there's a huge change in the way of teaching, thanks to MOOC, because we can gain immediate feedback from the attendees, so we can improve the way we are going to teach. Of course, you are going, and you should criticize my lesson, but I will receive the notes probably in 1 or 2 weeks. So it will, okay, I will improve my lesson, but at the very moment, okay, the course will be done. So I think that's the future. Currently, in antimicrobial stewardship, there's not so much things, I must admit. There is 2 MOOC available specifically on AMS. The Stanford one, I've done it. It's not that good. It's not bad, but basically just video of very competent people explaining their point. It's not bad, but it's not what it could be. You know, I just read the word Stanford, I thought it would be fantastic. It's okay. The BSAC one, I didn't do it. I think I will do it one day. It's managed by Dilip Naswani. And I think it must be good because Dilip is very good at teaching. So I would recommend it if you want, and it's free. Of course, if you want to have the diploma, you have to pay a small fee, but you can have access to the information without paying. So if you just want to gain knowledge, it's free. If you want to gain knowledge and a diploma, it's a couple of dollars. So not a big problem. Of course, and if you are interested in antimicrobial stewardship, you can go to the SGAP website, which I'm managing, and I have to put some more information on it. So currently, it's not at the top, but it will be in the next months. And okay, I'm late. There's another point I want to discuss with you is the telehealth. So according to, I don't know where, maybe it was Wikipedia, the definition of telehealth is the use of telecommunication techniques for the purpose of providing telemedicine, medical education, and health education over a distance. Basically, it's a way to improve access to service and specialty care for people living in a remote area. Remote area could be a suburb, because it's just an easy way to have access at distance. So, what can you do with telehealth? In MS, you may want to use pre-authorization, you know, to organize individual patient ID consultation, AMS ward round. You can use it with telehealth through video conferencing, Skype, remote access to electronic health records. You don't need to be in the hospital to access to the file of the patient. You may want to do post-prescription review. You can do that with video conferencing, Skype, and also, again, remote access to the file of the patient. And you can provide education. You will have access to the slide, don't worry. Okay, so I'm a little bit late, so I will go fast for this. So I think that the most interesting part with information technology. Okay, it's useful, it's a tool. But just think about something. It's going to generate a lot of data. There is a lot of data already existing, but they will put in a they will be centralized. So it will generate more data, a lot of data, big data. What is big data? Okay, no Wikipedia. I'm going fast with that. The definition of big data is a lot of data without sampling or aggregation. All the data potentially useful should be available. Of course, it's big. It's very heterogeneous. It may combine text, photo, numbers, whatever you have. And it's usually available in real time, so it goes fast. The interesting aspect of big data is that with big data you will have access to machine learning. Remember, in traditional data analysis, you have an hypothesis, you test the hypothesis, and then you draw your conclusion. In machine learning, you don't start with an hypothesis. You search for patterns without a priori. And I will use an example. So the idea is to find patterns without a priori. And let's show an example out of the healthcare system. Thanks to data mining, Target, an American supermarket company, was able to discover that to put diapers close to the beers resulted in an increase of beer sales, but only on Friday evening and on Saturday. That's what the data said. Of course, don't say why, but you can guess why. Yeah? Tell me.
Because fathers goes.
You are good. Because men sometimes go to the supermarket to buy diapers, but usually when they do it, it's on Friday afternoon and Saturday. So it's useful to put beers close to diapers on Friday afternoon and Saturday. So if it's work for marketing, you know, when you go to the supermarket, the Decathlon, usually they ask you if you've got the card of the shop, you know, and you may gain a couple of bucks in 10 years. So the interest is not to give you a promotion. The interest is to have your name, where you live, your sex, your age. So they can design promotion especially for you, to make you buy things. So if it worked for marketing, why not for antimicrobial stewardship? And it worked for baseball, and I recommend this movie. It was quite good. There's a guy called Barack Obama, you may have heard about it. He was able to win his re-election thanks to data mining. Okay, I will go fast for this because we don't have time, but okay, just remember that information technology, computer decision support system are a very fine way to provide data that could be able to use for data mining. So we should be able to find new patterns, a new way to practice medicine. But remember, it's only tools, just tools. Can, on the own, it was nothing. So remember, Mark Twain, if your only tool is a hammer, everything starts to look like a nail. And if you are not comfortable with computer, just ask your kids or the cat, and they will be able to help you. That was usually what I do. Okay.
Thank you.
Yes.
Respect of this one.
Okay, yeah.
So thank you for a very interesting lecture, but maybe take a few questions now, or we postpone for the second and have questions afterwards. Okay, so we'll just continue with the next lecture, and discussion will follow.
No, that's not what I want. No, this one. It worked. Oh yes, it's in this one. Okay, so now on the following presentation, I will focus on computer decision support system. Because it's basically what we need and the most advanced system to help us in for antimicrobial stewardship. So, what is a computerized decision support system? So basically it's a program that generates diagnostic and therapeutics recommendation from patient-specific information that was input in the system about the suspected diagnosis, such as the presence or absence of specific signs or symptoms. It has been called medical artificial intelligence. Of course, beware when you heard about artificial intelligence. After all, it's just a computer. Intelligence is a big word. But it's helpful. So, put it simply, it's a system that links all the information available in various databases in the same place. So, this is what looks like information system in your hospital. So I don't remember what the colors are, but you can imagine that in yellow this is your ward, in blue this is a lab, in red this is a pharmacy, and in green it's the radiology, and here it's I don't know what. So many different systems are operating at the same time in parallel, and they are not standardized because they were developed their own, and they are usually not communicating. So many years ago, some people tried to go toward a common language for interoperability between systems. The name of this language is HL7, health language. So it's not very recent. It started in 1987. Currently we are at the version 4, I think so. So you don't need to know much more about that, but just know that there is some specific languages developed in order to bring interoperability between systems. So just remember the name HL7. And this is my favorite part of the presentation, to show that computer decision support systems are not very recent. This is from a publication, the first publication about such system were in the New England Journal of Medicine in 1998. So, of course, it takes place in Salt Lake City, in Utah. You know, the city of the Mormon. And these guys are genius for databases. You know, they're very famous for, how do you call that, you know, when you want to, I don't know the name, I don't even remember the name in French, when you want to know what are your ancestors, genealogy. And they've got huge database for genealogy, so they love database. Of course, so they try to put database in the hospital. And they try to assess what was the impact of electronically identified intervention. So it was, they focused on an ICU, a 12-bed ICU over 1 year. So it was 545 patients. And they compared outcome during this year compared to the 2 previous years. And they were able to show that there was a decrease in inappropriate antibiotic dose, antibiotic-related event, and total cost of care. And this is how it looks like. Okay, it's very basic. It's very 1998, but everything is here. You've got the patient, you've got the last white blood cell result, the last temperature point, the weight, the ideal weight, if creatinine, renal function. So you know if you need to adapt. You've got allergy, you've got the current antibiotics, you've got the pathogen, you've got everything on the same place. Okay, it's basic, but it's useful. It's just what we need. 20 years ago, isn't it? And what did they show in the article is time spent on antibiotic prescription was 3.5 seconds with the system compared to 14 minutes with the paper, with the previous system. So they gained time. The cost was decreased. Patients received fewer antibiotic doses. There was a shorter length of stay, and there was a decrease in adverse event. There was no impact on mortality for this study. So the evidence, is computer decision support system useful? Yes, they are. So There's a lot of studies about that, but here you get, I pick up 7 studies which are, I think, interesting, which were able to show that there was an improvement on the choice of antibiotic. There was a global reduction in antibiotic usage, a reduction in broad spectrum antibiotic use, shorter length of stay, a reduction in adverse event, a decreased mortality only in one study, this one. An increase in pharmacy intervention, reduction on time spent. So if you spend less time, it's going to cost less, and of course the costs are decreased. Many systems are available. You can find tons of systems, from the simplest to the most sophisticated. Here is another course. It's from Canada. It's a quite complicated, quite complex system. What kind of alert can you find in this system? The most basic alert is bug-drug mismatch. The fact of having a positive culture but no antibiotics. You know, there's positive culture but nobody told you you could forget to put antibiotics. On the other way, a patient who have antibiotics but without positive culture. The possibility to switch from IV to oral. The duration of therapy, the fact of having duplicate antibiotic application, dose adjustment according to when people have impaired renal function, and you can have targeted specifically on some antibiotics such as carbapenem, etc. So let's have a few examples. For example, patient having received vancomycin for more than 3 days without positive culture. It's a nonsense, but you can just program an alert, so every patient in this situation will be signaled, and you can do something. Patient receiving piptaz and metronidazole, which is nonsense. Patient eligible for conversion from IV to oral linezolid. Levofloxacin at full dose with renal insufficiency, could be painful for the shoulders. Or having a positive blood culture for candida albicans and no antifungal treatment. That happened in my hospital once. You know, I was used to say to the resident, okay, you know, when you've got candida albicans in the urine, most of the time don't pay attention to it. And he thought that because I didn't pay attention to the urine, he shouldn't pay attention to the blood. And so he told me 24 letters. If I had a computerized decision support system, I would have been able to identify this patient earlier. It's interesting to know that such systems were developed originally not for antimicrobials, for other fields. In particular, it was designed originally to manage anticoagulation into the hospital. So, okay, now I've made the marketing part. It's wonderful. It's a nice computer system. Blah blah blah. So let's go in the. Now let's start to criticize. Is it the only tool? So I like this study. So they focus on what kind of intervention will be able to reduce inappropriate prescribing for acute respiratory tract infection, and they found that what worked was education of the parent, patient clinic and clinician combined education, the use of procalcitonin, and electronic decision support system. So yes, it worked to reduce inappropriate prescribing, but it's just a tool among others. It works, but it's not the only tool and not necessarily the best tool. So this is not the only tool. How is it the best tool? This one was fun too. It was dedicated to primary care practice, again focusing on antibiotic bronchitis, and it was randomized. There are 3 arms. One arm was usual care. The second arm was education through a poster. So in the waiting room, they had a huge poster explaining what should be done, and in case of acute bronchitis, do you have fever, do you have blah blah blah, then you should receive antibiotics, you shouldn't receive antibiotics. And they had a computerized decision support system. So 3 arms, many patients. So at the end, the final study of the population was huge. So yeah, good study, American way. So that was the poster. So you know, probability of pneumonia, low, intermediate, high, do nothing, consider antibiotics or at least a radio and do something, blah, 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 blah. So it was a paper and there was a computer system. What was the result? On control, nothing happened. So there was even a small increase in antibiotic prescribing, but it was nothing happened. Print-based arm, there was a decrease. So to educate patients with and doctors with a poster, it works. And computerized decision support arm, it works a lot. So yeah, it works well. But so this is the prescription of the prescriber compared to the previous year. So control, okay, nothing happens. Sometimes it decreases, sometimes it increases. Printed, it decreases in general, and computer, it decreases. But there was no difference between the poster and the computer. So yes, it worked, but it worked not better than the poster. Is it less interesting? No, I wouldn't say that. I think it's interesting because you've got additional benefit with the computer. You can edit the report easily. It's a general tool, so you don't need to print another poster every time you want to focus on another infection. It's something to do, very easy to do. On the other hand, when it's a poster, you have to design another poster, it's a lot of work. So thanks to the computer, it will be easier to perform an intervention. But the result is good, but not better than the poster. But it's easier to do. And also what you can do with the computer, easier, in a more easy way than with the poster, is that you can measure adherence, which be able to justify your wage and the cost of your MS team. So it's useful, but it's not the only tool, it's just a tool. Does it work for everybody? Maybe not. So again, so UK, a study based in UK, 2 label, usual care, computerized decision support system focusing on respiratory tract infection. Thousands of patients. No, yeah, that's here. Computerized, usual care, tons of patients, blah blah blah, female, young, old, whatever you want. What they show that the prescribing rate in antimicrobial decreased for adults between 15 and 84. For the youth, no change. For all people, no change. So here is a curve with the data, here is a curve with the model. So yes, for some patients it works, for the kids not so much, for the old people not so much. So it's a useful and powerful tool, but it doesn't work for every situation. But they were able to show that it was safe, there was no increase in complications, so it worth it. Is there a long-term effect? So yes, this one is from Sherbrooke in Quebec. So again, a quasi-experimental retrospective study with very good methodology and comparing the system before and after, but very good. Antimicrobial consumption before, after. Cost before, after. So yes, it worked, and it worked for many months. Length of stay, before, after, before, after. So this is for antimicrobial non-concordant, the proportion of non-concordants. So yes, it worked. Or maybe it worked just for a certain amount of time. Just remember that it is an intervention. So when you put the intervention in place, it works very well. But with the time, the impact will be less and less effective. So another study, the interesting part of this study is that they were able to show that using a common system between different hospitals is efficient, and it's a way to share the cost and to share common guidelines. And what they are able to show is that okay, it worked, but after the time, the influence of the system decreased. So my conclusion would be it's a tool, a very efficient tool, but it won't replace the team. The general idea in information technology is that the computer is not working better than a human. What works very well is a collaboration between a human and a computer. That's the most efficient way to work. But a computer in its own, no. Sorry, I'm a little bit late. I'm at the end of the presentation. So there was a literature review on can this system can trigger behavior change, because that's what we aim to do in antimicrobial stewardship, to change behavior. Okay, so this system could improve the use of antibiotics, but could it change the behavior in general? And because that will have an impact on a very long term. According to the British, not so much. Basically, the message was to say, still, we don't know how to assess properly such system. We don't know how to use them in the best way to trigger, to implement behavioral change. According to, I think the American, it could be, yes. You could trigger changes, but under certain conditions, depending. So I recommend this paper. So they are able to show what works and what don't work. What are the barriers and what are the facilitators. So if you want to implement such a system in your setting, you should read this paper, Keywords in BMC, Medical Informatics and Decision Making, because they put a very long list, it's a huge paper, a very long list of what works and what works not so well. But at the end, the conclusion is it's not miraculous. It could work better under certain conditions, but it's not miraculous. And remember, it's a source for big data. So, as a conclusion for my both talks, if you want to implement a computerized decision support system, first determine your objectives and take your time for that. What kind of information do you need? What is the gap between your current situation and your objective, and the gap with your current digital tools? Because you probably have smartphones, or you don't start from scratch. And just focus on all the manual interventions that could be done by computer in an easy way, so you will save time. Choose a very modular system. The tool should be adapted to your needs. You shouldn't spend too much time to adapt to the tool. And implement a system with option for big data. And I refer you to the CARD system developed by McMasters. And you can go to the website and it's quite fun. Remember, if your only tool is a hammer, everything starts to look like a nail. Thank you. Oh, before I finished, if you are very interested in antimicrobial stewardship, in ESGAP we've got tons of courses every year, so please feel free to come and play with us. And I was contacted recently for a postdoc position in Canada, not for me, but for people I know, on artificial intelligence and antimicrobial stewardship. So you don't need to be a genius in informatics or a genius in antimicrobial stewardship, but you need to have an interest in public health. So, and Canada is a wonderful place. Believe me, I just come back from Canada. So there is, I was contacted for a position in Quebec. So it's not exactly university, it's INSPQ, Public Health Institution for Quebec, but there is also a position for in British Columbia and in Ontario. So go to the website. I think it's Health System Impact Fellowship, and the deadline is it's close. So if you're interested, it may be fun. And if you got problem with computer, just ask for help. The CAD could be useful, according to my daughter.
Thank you very much for
Thank you.
very interesting.
We will start with a session dedicated to common infections, starting with respiratory tract infection, urinary tract infections, then the implants, that this is a field topic that is becoming more and more common, and we will end with the treatment of sepsis. I think everything focused on, we will focus on antimicrobial therapy. So my task is to tell you something about respiratory tract infections. So it's a kind of a mission impossible. If you look at the list of various respiratory tract infections, and if I want to tell you at least something about everything, we will end up with a nonsense presentation, a kind of a cookbook list or something like that. So I will focus on only two syndromes: acute non-specific respiratory tract infection and pneumonia. The reason I've chosen the two topics is that give some supportive therapy, and that's it. In general, this is really true. This is something we teach our students, we teach our younger physicians. And at the same time, it is the topic, the syndrome with probably the most mistakes in terms of appropriate antimicrobial prescribing. This is an American study that showed that almost 1/2 of the patients with respiratory tract infections that rarely represent an indication for antibiotic treatment received antibiotic treatment. So these were mostly viral diseases, and up to almost 1/2 received the treatment. So in the field, the problem is far from being really solved. This is another more recent study. I showed you actually this study yesterday already. And in UK, they did a large study. They look at the common respiratory syndromes, common infections, and they formed a group of experts that decided for each situation if the patient needs antibiotic or not. And this here is the proportion of patients that are in need for an antibiotic by the group of, in opinion of the group of experts. And this was the actual prescribing in the same patient. You see, huge difference. So a lot of room for improvement. Perhaps it is easy to decide in an office, you discuss the patient and so on, and a GP in his practice, you know, the patients are very frequent, so it's difficult to decide. But nevertheless, the difference is really, it's not 1/2, it's a factor. So a big difference. Although, though, we can look to the problem more carefully. There are some studies that look at the outcome of the patient with chest infections if they get an antibiotic and if they don't. This is a study also in primary care, published a couple of years ago. They looked at a serious and minor adverse event related to antibiotic therapy, and they also looked at, these were the patients with, as I said, acute respiratory tract infections, if they developed then pneumonia or not. And really, a really great big number of patients, and 65 of this 1 million and something receive antibiotics. You see that there was a difference in serious adverse events, but very minor one. These are the events, not the percentage. This is, you know, the events per 100,000 patients. Then minor adverse events, of course, were much more common in patients with antibiotic therapy. Minor adverse event, of course, is not something that would bring a patient to the hospital, but sometimes even minor adverse event might be unpleasant for somebody who would like to go back to work, to school, and so on. So minor by the definition of an adverse event, but actually perhaps sometimes at least not really minor for the patient. And then they looked at the pneumonia, and you see again there were 22 almost cases per 100,000 patients with, no, it was vice versa. Oh, sorry. This was with antibiotic therapy, and this was without antibiotic therapy. So there was a difference. The patients who got antibiotic therapy had less pneumonias then later on than those who did not. Well, so the figures are really few, like 18 versus 22 per 100,000. So if you calculate the number needed to be treated to avoid one pneumonia is 12,000. This is far beyond what we accept as an indication for a treatment, for an intervention. But still, a significant difference. And what is also interesting in this study, the difference in pneumonia rate became non-significant when they excluded pneumonias diagnosed on the same day when antibiotic was prescribed. What does it mean, actually? The authors of the study discuss, of course, this change in the significance, and they said perhaps antibiotics given on the first day prevent the development of a very, very rapidly progressing pneumonia. This is one thing. And the other, much more plausible, is that the difference was caused by misdiagnosis of pneumonia on the index day. Actually, the patient already had pneumonia. It was misdiagnosed, and that's why it was more helpful to get antibiotics or not. So it's not so completely still. We do not recommend antibiotics for such situations. Another, a bit older study looked at the individual syndromes among respiratory tract infections. And as you see, in otitis media, there was a significant difference with antibiotics or not, but the number needed to be treated in otitis media, in sore throat, in chest infection was more than 4,000. Again, a lot to prevent a complication. Complications were, of course, different. Otitis media, mastoiditis, sore throat, quinsy, the abscess, and in general, it was pneumonia. Also for pneumonia, there was a significant difference, and but a big number should be treated to prevent one case. So, but you see, there is. So here, in upper respiratory pneumonia, it's difficult to miss if you don't give an antibiotic. In otitis media, again, it is difficult to miss. The same thing with sore throat. If you think you do not need to treat with antibiotic, it's difficult to miss. Many patients to be treated to prevent one case of complications. But if you look at the chest infection and pneumonia, chest infection is already more localized. This is the patient that comes in with so-called bronchitis, not upper respiratory tract infection. Here, of course, the situation is different. These figures here around 100, 96, and so on are still quite high. But in elderly people, you see, it became lower. So I think it's quite clear to get an idea from this slide where we have to be really careful and where there is no problem. We can decide on the clinical basis in the office, no problem. So these are the situations where can we safely avoid antibiotic treatment if this is our decision. And in chest infection, especially in elderly, of course, there might be a problem. So our decision goes towards prescribing an antibiotic treatment. What do the guidelines say about the same problem? The most recent, okay, this is now 2011, no new guidelines, but actually not many things are different. We do not have any new antibiotics and so on. So they actually advise to look at the signs and symptoms and also on comorbidities. And new focal chest infection, of course, on auscultation, then dyspnea, tachycardia, and fever already for 4 days. In all these cases, of course, the balance goes toward prescribing an antibiotic. And with the comorbidities, cardiac failure, insulin-dependent diabetes, and serious neurological disorders such as stroke and so on, again, towards prescribing an antibiotic. And this is a recommendation that takes into account the CRP. Again, something that might be helpful, but in many cases, this is the gray zone. But if we have really low CRP, no antibiotics, if it's above 100, an antibiotic is suggested. It might be pneumonia, not just bronchitis. And here in between, we may decide for the delayed treatment. This is something that is well organized in some countries. The patient have the ability to call the GP and they discuss again and so on. And in some countries there is some problem, as I discuss this thing with my colleagues in other European countries. So these are these basic things about the decision on antibiotics in patients with apparently viral chest infection. And what can we say? We have to carefully evaluate the patient with chest infection, look for pneumonia if it's chest infection, consider risk factors, and what we need is better diagnostics for community-acquired pneumonia. If we had better diagnostic, we would certainly have an opportunity to limit, to decrease the use of antibiotic in outpatient and also in inpatient sometimes, on the field, in the domain where the most mistakes in antimicrobial prescribing are made. So this is about acute respiratory, presumably viral infections. Then a few words about appropriate antibiotic use in pneumonia. This is one of the more recent slides on etiology of pneumonia. This etiology is more or less the same for many years already in different countries. The study is from the Netherlands, but I put it on the slide only because it was one of the most recent. Strep pneumonia, this is, oh yes, this is ambulatory, and this is in the hospital, and this is ICU. All the rest is, and this is unknown etiology. Sorry. So you will learn some Slovenian. So in ambulatory, we have strep pneumonia, we also have Haemophilus influenza, we have some mycoplasma, and then we have viruses. In the hospital, you see, we have the highest figure is with strep pneumonia, and then all the rest is less. And then in the ICU, again, strep pneumonia. Here we speak about Staph aureus. In ambulatory, you will not find it. Some viral Legionella in this study is not so prominent, but the more you go to the south, there is more Legionella. That might be different, and it also depends on some outbreaks and so on. So what can we say in general? Strep pneumonia is the most frequent causative agent still, but the frequency, in fact, is not really high. In no study that looked at the etiology of pneumonia, of course, it's very difficult to diagnose pneumonia, even in a study. But even in these studies, strep pneumonia is most prominent, but it's not like 60–80% of everything. So we have to be aware about other etiologies. Then, of course, always the problem of Haemophilus and Enterobacteriaceae that might colonize the respiratory tract and contaminate the sample. And then the problem with diagnostics of C. pneumonia. We usually do a molecular test now, but if you still rely on serology, it might be wrong. No major change, as I said, similar results of other European studies. This was about etiology, the bacteria. But if you looked at the susceptibility, this is a slide presenting the resistance to penicillin in strep pneumonia. This is now this atlas at ECDC. I preferred the previous way how to present the data, but okay. You see the range in Europe. This is the high level of resistance, above 2. 0 to 45. There are countries in in Europe with almost 1/2 of strep pneumoniae isolates that are highly resistant to penicillin. This is, so it's very difficult to speak about some guidelines that would be, you know, as usually the antibiotic guidelines are local. I don't know, for the treatment of hypertension or other syndromes, you can have international guidelines. But for antimicrobial treatment, not so. Then the other question always is the susceptibility of strep pneumonia to macrolides. Again, a European map, and again, a huge range. There is no zero country, even the best countries come with 3.6, okay? To more than one third. So again, a large difference. This is a situation in Slovenia. Of course, the susceptibility of pneumococcus, you know, depends upon the localization of infection, because nowadays it takes into account the clinical efficacy. And in Slovenia, we are good with cefotaxime, of course, with amoxicillin and ampicillin, 85% susceptibility. Meningitis, oral is around 84. So that means 16% is MIC2 and above. But the problem lies, actually, our real problem is the resistance to erythromycin, to macrolides, that is still around 1/4. It was much more a couple of years ago. It's going down, but really, really slowly. General principles of antibiotic treatment of community-acquired pneumonia, also, of course, related to appropriate use of appropriate choice of antibiotics. Never forget strep pneumonia. As I said, it does not cause 80% of all pneumonias, but it's always there with the risk is still high enough that we should always cover strep pneumonia. And then the selection of empirical antibiotic therapy should be guided by the severity of the disease at the presentation. This is quite different from the recommendations that we had like 20 years ago. I still have discussion with some older colleagues who say we have typical and atypical pneumonias. Okay, yes. If you do a very large statistics, you will see that some people with their symptoms and signs group and as atypicals, and the other group as typical pneumonias. But if you speak with one patient in your office or on your ward, it is much too dangerous to speculate and say, oh, I think this is atypical. I will treat with a macrolide, and you have 23% of resistance in pneumococcus. Dangerous thing to do. So the advice in modern guidelines is to look at the severity and, of course, expand the spectrum of antimicrobials that you prescribe to cover this greater risk for other pathogens. Of course, severity assessment, pneumonia severity index that has been studied, but it's rather complex. You need laboratory results. You need some time to calculate all this. The good thing in this pneumonia severity index is that women are 10 years younger than men. In women, it's age, and then you can take 10 years less for the points. So that's why I remembered always. And then, so usually in recent guidelines, you will see the most commonly used is the CRB 65. You know what this all means. It is actually reflects the mortality. And this is then the reason what to do with the patient in terms of admission or not, and also in terms of the choice of antimicrobial treatment. A very hard nut, we say in Slovenian, I don't know if there's translation in other languages, is combination empirical treatment for CAP. You will see this and that, and new studies being published with conflicting results. What can we say at the moment? Okay, these are different countries where studies were published. Switzerland, comparable efficacy of monotherapy and beta-lactam plus macrolide, a trend toward better efficacy of combination in severely ill. Then the Dutch study, the same efficacy in patients who do not need ICU. Then a meta-analysis, better efficacy of combination, but poor quality of the studies. Of course, you can do a great meta-analysis, but if the study you take are bad ones, so. Then comparison, another meta-analysis, advantage of the combination in more severely ill, above 2 or pneumonia severity index 4 or 5. Then another study, comparison of beta-lactam plus macrolide combination with fluoroquinolone, longer hospital stay and higher mortality in patients treated with fluoroquinolones. So they do cover everything, but it looks that it's better to combine the two, the beta-lactam and the macrolide. So, well, difficult to say what to do. Even before the publication of some of this study, the British authors, the NICE group, decided on recommendations that I put on this slide. In general, combination therapy is not superior to beta-lactam macrolide combination in, monotherapy is not superior to the combination in mild CAP. So don't use combination therapy in mild CAP. In more severely ill patients, there are no solid data to support the combination therapy. So a gray zone. In severely ill patients, the combination treatment is recommended because of high mortality and potential of higher efficacy of combinations. So in this middle group, we say the data are too few or they are not convincing. But for the more severely ill patient, of course, data are not convincing, but because of the higher mortality, it's probably wise to do something, although the evidence behind is not so high. So this is the logic, the logistic. And of course, there is no difference with fluoroquinolones and taking into account the study. So there are many reasons now to avoid quinolones if possible. Just a few words now about recent guidelines from different European countries. What do they recommend? This is the previously mentioned European, the ESCMID, then Sweden 12, the Netherlands in 2016. This was revised guidelines from NICE, published by British Thoracic Society. Outpatient, amoxicillin or doxycycline. Amoxicillin. What we have to cover here is pneumococcus. All the rest is not relevant. Inpatients, more complicated. Here, most guidelines take into account the severity index and try to recommend different treatments. NICE. These are the patients who are admitted sometimes for other reasons, for decompensated chronic diseases, sometimes for social reasons. And here the treatment is virtually the same as in outpatients. In more severely ill patients, they do not go for the severity indexes, but in moderately severe pneumonia, they combine amoxicillin, not amoxicillin clavulanate, amoxicillin, pneumococcus, and then macrolide. In severe pneumonia, of course, beta-lactam resistance against beta-lactam as plus. They start with the plus already, just after the group that were admitted for actually other reasons. This is different from ESCMID. They actually put plus minus macrolide, and this is the individual physician who decides to do it or not. And so on. And in more severely ill patients, they recommend third generation plus macrolide or MOX-LEVO plus minus third generation. The problem is that in some countries have resistance to quinolones in pneumococci, of course. And here, of course, we replace third generation, or we go for cephalosporin that is active against Pseudomonas. So a slight difference here, it's plus minus. And they also recommend or aminopenicillin and beta-lactamase inhibitor. Why do you think it is there are so many choices in ESCMID guidelines? Yes, because it's so difficult to get consensus for two reasons. The resistance patterns are different, but there is one more thing. People are used to one type of treatment, and we all believe that what we do in our hospital, in our office, is the best thing. So this is something we would like to have in the guidelines. So it's like European Union, no difference. In patients, if we continue, the British, the amoxicillin or parenteral, and then from here on, parenteral also moderately severe, still the index is low, plus clarithromycin, plus macrolide orally. And then in more severe, they extend this towards amoxicillin clavulanic plus. So actually, if it's moderately or more severe for in the UK, they always combine. They always think about mostly Legionella. In the Netherlands, they start here with the patients who are admitted. You see Pen-G or amoxicillin. These are already, I would say, moderately severe ill patients who are admitted to hospital because of pneumonia. In the Netherlands, they start with Pen-G and amoxicillin. And then if the patient is more severely ill, they go for higher generation cephalosporins. And only in patients that go into ICU, they cover for the so-called atypicals. So quite different. The Swedish, very similar, but here they start sooner with the recommendation on macrolides. So again, we have to think about not only the resistance patterns, but different prescribing habits, so to say. I was at the course a couple of 3 years ago now. We had, we were from different parts of Europe, some from the south and some from Sweden. These were ICU people, actually. And there was really a debate among the participants what is the right thing to do, because for somebody from the south of Europe, they never give penicillin in an ICU, so even if they have an isolate. These are the Slovenian guidelines, not translated on purpose. For ambulatory treatment, amoxicillin, penicillin, 5 days, and then doxycycline or midakamycin, preferably not Claritro or Azitro because of prolonged half-life and the problems I mentioned before. We have the macrolide resistance, and then in inpatients, amoxicillin plus minus, and if it's more severe, we go to clavulanic, and the most severe, the ICU, is the third generation. These are the new, this is still a draft version. We have to discuss it. We have discussed it actually with GPs and pulmonologists, but we haven't, do not have a conclusion yet. It has not been published. Then we have the so-called directed empirical therapy. We know already something on the pathogen, so we can choose, our choice is narrower. We can give high dose of penicillin based on positive pneumococcal urinary antigen. High dose because we do not know anything about susceptibility. As you've seen, we have like 15% of lower susceptibility. So, and then the other possibility that is also, because urinary antigen may be available in a couple of hours, and sputum smear as well, so we can give high dose of penicillin based on positive sputum smear. Well, The first recommendation actually comes partially from a study. They looked at they actually randomized patients, and they looked at the patient with pneumococcal antigen, and then the patient had urinary antigen positive, and they decided for the targeted treatment. And in control group, they didn't. And there were more relapses, but of course, few patients, more relapses in targeted treatment when if they decided to give penicillin because of positive urinary tract antigen. So, and they looked at these 3 patients, why it happened, why it went wrong. The decision was not the right one. They probably missed something, although the urinary antigen was positive. You see, this is really, really low. The significance is not really convincing. Of course, very few. One of the 3 patients actually had with a relapse, had actually E. coli bacteremia. So probably the pneumonia was not really well diagnosed. I don't know what was the treatment in the other 2. If there were macrolides, it was possible. Directed therapy with macrolides, there might be some resistance and so on. This is our experience. We haven't done a study yet, but just we looked at what is going on, and 300 and something patients in a year, 115 microbiologically confirmed. Out of them, almost half pneumococcal pneumonia, and 17 confirmed only by urinary antigen, and in 13, not in all, it also, of course, depends upon the attitude or some circumstances that were not really convincing for pneumococcus. Actually, we had the pleural drainage in one of them, and all the rest was non-problematic. So we do take it into account in the clinical practice, but of course with the reliable diagnosis of pneumonia. For the conclusions, beta-lactams are the mainstay of antibiotic treatment in community-acquired pneumonia. No use to prescribe fluoroquinolones, and especially not macrolides. Also not macrolides. And then, of course, local epidemiology should be taken into account in local guidelines. Not only the spectrum, but also the potential to cause resistance. As you've seen, we would like to change our prescribing habits, especially in outpatients, from macrolides in patients who are allergic to beta-lactams to doxycycline, if possible, and if not doxycycline, then this short half-life macrolides such as midakamycin. To improve the susceptibility of our pneumococci to macrolides. So thank you very much. This was it. So our next speaker is Matea Lugar on urinary tract infection. Again, something very common.
It is nice to meet you all in Ljubljana. It is my pleasure to speak to you. It is not something really fabulous about speaking about urinary tract infections, even those infections are very common, and they are the frequent reason for antibiotic prescriptions. So it is a huge group where we can apply principles of antimicrobial stewardship. We can divide urinary tract infections into lower and upper urinary tract infections. In lower urinary tract infections, we are dealing with urethritis, cystitis, and prostatitis in men. And in upper urinary tract infections, you know we have pyelonephritis and possible urinary abscess. We can also divide urinary tract infections into uncomplicated and complicated. That means that the course of the disease and the possibility of complications are low in uncomplicated infections and higher in complicated. We have here urethritis in male and female, and in uncomplicated we have cystitis and pyelonephritis in unpregnant, healthy young women. All other entities in urinary tract infections are complicated infections. So it is very simple. In uncomplicated cystitis, we are dealing mainly with Escherichia coli, followed with Staphylococcus saprophyticus, and then Klebsiella and Proteus. But in complicated infections, the spectrum of bacteria is a bit wider. Escherichia coli is still the most prominent pathogen, but there are more, the incidence of other Enterobacteriaceae is higher, and we are also finding here Pseudomonas and Enterococcus species. It is also the dogma that in complicated infections there is more polymicrobial infections and the bacteria are more often resistant to antibiotics than in uncomplicated infections, which are mostly found in the community. I will spend a couple of minutes speaking about asymptomatic bacteriuria. You know, it is a finding mostly from the lab, so you are sending the urine sample from a person who doesn't have any signs of or symptoms of urinary tract infections, but you find the significant number of bacteria, just one species in the urine sample. The prevalence in the young healthy female is low, but in elderly patients, especially those who are in the nursing homes, is quite high, and in those who are having long-term urinary catheters, it can approach 100%. The etiology is very similar to the etiology of the complicated urinary tract infection, so that is something you have to keep in mind when you get the results from the microbiology lab and the patient does not have any symptoms. So it is don't look for it and don't treat it. There are just a few exceptions. During the pregnancy, the asymptomatic bacteriuria can progress to symptomatic infection, which can have some unpleasant outcomes like a preterm birth or low-term infants. And it is also wise to look for asymptomatic bacteriuria in the patients who will have invasive urological procedure, because it is known that in those patients the incidence of complications like urosepsis is much higher than in those who don't have asymptomatic bacteriuria. So you treat those two groups. There is always a question about kidney transplant patients. The European Neurologic Society advised against looking for asymptomatic bacteriuria in the treatment in that group of patients. In the article published this year, it is also said a bit different than it was previously in the United States, that it's just reasonable to look for asymptomatic bacteriuria just in the first 2 months after transplantations and treat it, but after 2 months there is no need for the treatment and so no need for the searching for asymptomatic bacteriuria. So now we are with symptomatic urinary tract infections. So we have a patient with symptoms and signs of urinary tract infections, and in the urine we expect to find at least 10 to 5 colony-forming urines per milliliter of urine. Then we can speak that we have a confirmed infection. So the most common signs of lower urinary tract infection are dysuria, frequency, urgency, nicturia, and new or worsened urine incontinence. In upper urinary tract infections, we have patients with systemic signs of the infections, most often with fever, chills, pain in the costovertebral angle or flank pain. Patients are very often complaining about nausea, some are also vomiting, and especially in the elderly patient we can find changes in the mental status. What about infection with urinary catheter? They are common, you all know that. It is very important that you keep in mind that the colonization of the urinary catheter starts at the moment you put the catheter into the patient, because you cannot sterilize the urethra, so we are putting the catheter through the non-sterile portion of the urinary tract. And the biofilm is sort of formed after 48 to 72 hours after the insertion of the catheter. So the infections in the patients with long-term catheters are more often polymicrobial, and they're more often than in the rest of the population caused by multidrug-resistant bacteria. It is also known that the prognosis and the resolution of the clinical signs and symptoms is quicker when you remove the catheter at the beginning of the treatment, which is also important because you have to remove it or change it because of the importance of the microbiological results. This is the article stating the same as I have already told you. They have included 66 patients with long-term urinary catheter and the signs or symptoms probable or in concordance with urinary tract infections. And as you can see, if they didn't change the catheter, there was just 7 patients who didn't have any growth in the urine sample, but if they have changed the catheter, the proportion was quite high. It was already around 1/3. And heavy growth, like a significant bacteriuria, if there was no change, approximately 75% of patients have heavy growth, but after the change, the proportion came down only to a bit more than 1/3 of the patients, which was significant. And it was also true that majority of bacteria were isolated less frequently after the change of the catheter. The only exception was Pseudomonas, and they didn't find any proteus when the catheter was changed. So this study confirms that the failure to change long-term catheters before collecting urine for culture may give you misleading results. So you are treating the patients who have the urinary catheter colonization and some other kind of infection, not the urinary tract infection. And when you get the results from the microbiology lab back, if you didn't change the catheter, it is not the relevant results. Criteria for urinary tract infection. If you just take into account the history and clinical examination, you will correctly diagnose approximately 50 to 80% of urinary tract infection. Then you can have some different predictive factors which are in concordance with signs and symptoms of urinary tract infections and other factors like sexual intercourse in the past 2 weeks in the women, use of spermicides, vaginal diaphragma, or some other kind of local methylprogesterone preparates, if the patients were treated with antibiotics and have some abnormalities in the urinary tract, and also the patient with diabetes. These are all factors that increase the probability of urinary tract infections. Negative predictive factors are new or changed vaginal discharge and itching, which is more pointing toward the urethritis. And if you're just taking into the account history and clinical examinations, antibiotics are usually prescribed unnecessarily. Usually we take urinary samples only from symptomatic patients with spontaneous voiding. It is wise to take the middle urine sample with pre-treatment of the genital area, so the patients have to clean it. But you can also use the pragmatic approach with dipsticks, and if they are positive, you go to the additional laboratory and microbiological test with clean catch of the urine sample. If it's not possible to get the sample with spontaneous voiding, you can use single catheterization. And as I have already told you, when you have a patient with long-term urinary catheter, change it if it's in place for more than 48 hours. Aspirate it from the tube, never from the bag, because in the bag you have whatever you want to find. In pre-hospital, dipsticks are something that makes the life of the physician easier. It is difficult to get the right sample, so the negative results are excluding urinary tract infections. But you have to keep in mind that the transformation from nitrates to nitrates take at least 4 hours, so the urine have to be taken early in the morning before the first voiding, or the patients have to wait a bit before they give you a sample, and you can have negative leukocyte esterase and nitrates in some of the bacteria which do not break down the nitrates. If you have the positive results, then you go directly to the additional tests. All complicated urinary tract infections and clinically unreliably uncomplicated urinary tract infections need additional laboratory tests. So you perform the examination of the sediment, and if you don't find pyuria, you can exclude the urinary tract infection, except in neutropenic patients who don't have leukocytes in the blood, so they don't have it in the urine. You can then use the bedside test to identify the bacteria. You can incubate your urine sample during the night, and the tests are able to differentiate among the most common bacteria. And some tests are also able to give you some basic sensitivity to antibiotic. Sensitivity is quite high, but the specificity is not so good. The most common test is EUCIC, you know it. Then you can discuss about the density of the bacteria and also the species and also some sensitivity. The best is always the urine culture, which is not needed in uncomplicated urinary tract infections, but in all others you should send the sample to the lab before you start with the antibiotics. Then you get the identification, the significant bacteriuria, and at the end also the sensitivity of the isolated pathogen. What about blood tests? You do the regular lab tests like blood, complete blood count, markers of inflammation, electrolytes, urea, and creatinine. If you have the normal results of the complete blood counts and no other signs and symptoms for UTI, you don't need any other test for the UTI. You can exclude the UTI as the reason for the infection. Blood cultures are only taken when hospital treatment is needed, so that is in upper urinary tract infections, not needed in uncomplicated. When you have a patient with sepsis or you have a patient who are immunodeficiency, and when the diagnosis is not very certain, because more than 20% of patients with acute pyelonephritis have positive blood cultures, and there is no evidence that the positive blood cultures have any influence on clinical course or outcome. Here is a study which confirms that. They have included more than 1,000 patients with age approximately around 63 years. They have quite a lot of functional and structural abnormalities. They were immunocompromised in 16%, and 15% had long-term urinary catheter or nephrostomy. Urine culture was positive in 68%, 33% had bacteremia, 26% developed severe sepsis, and 12% septic shock. Mortality was 6.5%, and attributed mortality was 4%. And independent risk factors for mortality were age, immunosuppression, and septic shock at the admission, and was not correlated with the positivity of blood cultures. Imaging, abdominal or renal ultrasound in all complicated infections, followed with CT or MRI. Empirical treatment is quite difficult in the area of higher antimicrobial resistance. It depends on the type of the infection, sensitivity. That is why you need your local data. Especially in our country, we have majority of data from complicated urinary tract infections, and we have a higher prevalence of hospital isolates, so it is difficult to say that is also true for the community. In lower urinary tract infections, you want antimicrobial agents with high concentration in urine, and in upper urinary tract infection, you want an antimicrobial agent which achieves also high concentrations in renal parenchyma. The recommendations from European Urological Society and also followed in Slovenia are for the uncomplicated lower urinary tract infection, nitrofurantoin for 5 days, fosfomycin in 1 dose, trimethoprim or beta-lactam antibiotics for 5 days if the pathogen is sensitive. You can also use pivamycin for 3 to 5 days, which is not available in Slovenia. Fluoroquinolones are not indicated as the first-line treatment. You are using them if you have the sensitivity and the pathogen is not sensitive to other options. In complicated infections, you treat up to 7 days. In uncomplicated pyelonephritis, the Urological Society advised to use fluoroquinolones if the resistance is less than 7 days. If you are using 3-metoprim sulfamethoxazole or the third generation of cephalosporins in peroral way, you have to start with the first dose of a long-acting parenteral antimicrobial like ceftriaxone. Because you're coming from different regions, and I can't just show you data for all of your countries, I'm showing the data about the Escherichia coli in Slovenia. You see we have quite high resistance to amoxicillin with clavulanic acid, also to ciprofloxacin and 3-metoprim sulfamethoxazole. But it is a quite good situation with the second generation and the third generation of cephalosporins. It is much worse when we are having ESBL, then we are really having troubles with peroral antibiotics. In upper urinary tract infection, we can start the treatment with second or third generation of cephalosporins with the addition of ampicillin. We can also start with the aminoglycosides. When you have ESBL, then amikacin is better than gentamicin, and you have to add ampicillin when you think about enterococcal infection. Other options are piptazo, carbapenems in patients who are colonized with ESBL. Fluoroquinolones and amoxicillin with clavulanic acid are less appropriate because of the high resistance. Cephalosporins of fourth generation are limited for the hospital-acquired infections in patients who are not colonized with ESBL. And of course, now we have registered new cephalosporin, which are effective against ESBL strains, ceftazidime and avibactam, and ceftolozane with tazobactam. The usual duration of treatment is 10 to 14 days. The exceptions is the treatment with levofloxacin, which can be shortened to 7 days. But now we have some data that 7 days of treatment is as effective as 14 days for gram-negative bacteremia. It was published a couple of months ago. It was a randomized study, included patients with gram-negative bacteremia. First group, intervention group, received treatment for 7 days, control group for 14 days, and they have taken into account those factors as the primary outcome. 600 patients, majority with urinary source of the bacteremia, others were a bit less common. Escherichia coli was the primary pathogen. And the primary outcome was achieved in quite a lot of patients, more than 40% in both groups. There was no difference in any complications and any primary outcomes, and also there was no difference in the 14 and 28 days mortality. The difference was that the dose in the 7 days arm had shorter time to return to baseline functional status. So they conclude that in patients hospitalized with gram-negative bacteremia, achieving clinical stability before day 7, an antibiotic course of 7 days was non-inferior to 14 days. So it is something to keep in mind when you are dealing with that kind of patients. In urinary catheters or nephrostome, empirical treatments similar to those with upper urinary tract infections, just the duration is here shorter. You can treat just for 7 days with good clinical response. It does not depend on the antibiotics. 5 days with levofloxacin, and 10 to 14 days if the clinical response is not so good, and 3 days if you have a healthy younger women with signs and symptoms of lower UTI and urinary catheter was removed. When you have to hospitalize the patient, when you have a septic course of the disease, patients are vomiting and are not able to take the peroral antimicrobials, and when you have a pathogen resistant to peroral antimicrobials, but then you can put the patients into the OPAT, so antibiotics it's as outpatients. Patients are usually febrile for at least 48 to 72 hours, despite that you have the right antibiotic for the right pathogen. If those 72 hours has passed and it is not better, you have to think it's not the UTI, that bacteria are resistant, you have possible urinary tract obstruction or the kidney abscess. Acute infections don't leave any consequences, but when you have a repeated upper urinary tract infections, you can have a chronic renal failure as a consequence of the infection. Some patients have recurrent urinary tract infections. Risk factors are different in young premenopausal women than in postmenopausal and elderly women. And about prophylaxis and recurrent infections, we will talk tomorrow. So I will conclude that urinary tract infections are common. They are more prevalent in special groups. You have to think about asymptomatic bacteriuria. You have to think about your local resistance patterns, change the urinary catheter before you take your microbiology samples, and start with shorter antibiotic treatment. Thank you.
Dear colleagues, dear friends, I would like to tell you something about implant-related infections and the role of biofilm active agent. On this slide, you can see different device-related infections, and on the right, also tissue infections which are related with biofilm but not with embolic implants. Medical implants represent a great progress and success in medicine, but on the other side, you have a big problem when you can treat these infections. Surgical implants remain in the body for a long time, and they have no contact with skin.
It's difficult to hear you.
You can hear?
You can use a microphone from stage.
Thank you. On this slide, you can see the rate of infection is the highest among heart assist devices, about 25 to 50%. And infection of joint prosthesis is very important, but the rate of infection is low, about 1 to 3%. And the highest rate of mortality was found in heart assist devices, mechanical heart valves, pacemakers, vascular grafts, etc. But it seems that the rate of infection much be higher than those listed there. The major problem, as I can tell you, is implant-related infection, and which increase the medical cost, prolonged hospitalization, multiple surgery, and medical supplies. And to cure this infection, long-term antibiotic therapy combined with appropriate surgery and removal of the implant is necessary. Antibiotic treatment without surgery is not recommended and should be only performed if the patient refuses surgery or the surgical procedure is associated with a high risk for patient life. Despite a significant amount of basic and clinical research, many questions about definition as well as diagnosis and treatment of implant-related infections remained unanswered. And so, ECMID guideline for the diagnosis and treatment of this infection was published in 2015 to help, especially for microbiologists and infection diseases specialists to treat these infections. In the pathogenesis of these infections, very important role play bacteria, besides the host factor and device. Implant is avascular. There is no protection against infection, prevented access of the antibiotics to the site of infection. As you know, planktonic bacteria very rapidly adherence on surface of implant and embed it in matrix, and there are no elimination by granulocytes. In contrast, bacteria in biofilm exist as multicellular complex three-dimensional structure enclosed by exopolysaccharides. They are in stationary phase of growth, are metabolically less active, and resistant to most antibiotics. Biofilm bacteria are protected. The development of a biofilm is a four-stage process: cell adhesion, cell aggregation, biofilm maturation, and cellular detachment. And on this slide you can see that formation of biofilm is very rapidly, in a few hours, few days, and after 3 weeks the biofilm is mature and cannot be removed. And early in the formation of biofilm, you must think about infection. The later in the biofilm, the lower is bacterial killing. On this slide, you can see the most common isolated pathogens. These are Staphylococcus aureus, coagulasa negative, Staphylococcus streptococcus, followed by gram-negative bacteria. Mixed infections are not uncommon. And what is the key to success in the treatment of this infection? The key number one is interdisciplinary concept. That means cooperation between microbiologists, infection disease specialists, and surgeons. And why is the biofilm so important for the treatment of implant-related infections? Usually used antibiotics have very poor activity against biofilms, cannot penetrate to biofilm, and biofilm bacteria are protected. In the presence of the implant, the minimum infection dose for Staphylococcus and for other bacteria is much lower. We can talk about minimal biofilm eradication concentration, which is higher than corresponding MIC. For example, for Staphylococcus aureus, required more than 10 times of MVC of vancomycin. And on this slide you can see the different bacteriostatic and bactericidal antibiotics, but not all of them are suitable for treatment of implant-related infections. It has been shown that staphylococcal biofilm can be eliminated by rifampin combination therapy and gram-negative biofilm by fluoroquinolones. However, the biofilm elimination is only possible if the infection not exceed more than 3 to 4 weeks, but total duration of this therapy has never been tested in a controlled studies. And what can we say about rifampin? Rifampin is usually used to treat tuberculosis, as you know, and is still only anti-staphylococcal antibiotic with good efficacy against biofilms in vitro, in animal models, and in humans. Rifampin has an excellent bioavailability, about 90 to 100%, can penetrate to white blood cells, and can eradicate adherent bacteria in the stationary phase. Rifampin penetrates well into all body fluids, and the concentration in the bone is very high. But the use of rifampin is limited by the rapid development of resistance and must be combined to the second antibiotics. Fluoroquinolones are ideal combination for rifampin, but the resistance increasing rapidly, and for ciprofloxacin in MRSA infection is about 85%. Rifampin combination therapy should be usually reserved for patients with staphylococcal orthopedic device infections treated with debridement or one-stage exchange. This is a group of selected patients, but not for suppressive therapy for a long time. Other oral combinations may be used, and on this slide you can see the summary of animal studies for staphylococcal bone and joint infections. Rifampin can be combined with other antibiotics, and it is effective, but there is a little data for patient treatment. And when is the optimal time to start treatment with rifampin, and why is it is important? In patients with staphylococcal orthopedic infections, the optimal time to start with rifampin therapy is not immediately after surgery, but after all drains were removed and the wound is dry. And why? Because the bacterial load is probably still high at that time, and patients treated with rifampin will select rifampin-resistant staphylococci. The published guideline for staphylococcal prosthetic valve endocarditis recommended the delay of rifampin treatment until blood culture have turned negative. On this slide you can see the latest instruction recommendation for the treatment of orthopedic infections, published by a research group from Berlin. And empiric antibiotic therapy depends on the local epidemiological situation and the information about a patient's colonization. As you can see, in the early staphylococcal infection, we can start intravenous therapy with flucloxacillin. If staphylococcus is methicillin susceptible, for 2 weeks, when wound is dry and drains are removed, you can add it rifampin, and then followed by oral route combination rifampin plus levofloxacin, cotrimoxazole, or doxycycline, or fusidic acid. Very dirty to try are infections where you have rifampin-resistant infection, in staphylococcal infection, or in penicillin-resistant enterococcus infection. Oh, sorry. I'm sorry. And in gram-negative infection that ciprofloxacin is resistant, or in infection by fungi. There are instructions for the therapy for endocarditis involving a prosthetic valve or other prosthetic material caused by staphylococci. And as you can see, it is proposed to use nafcillin or flucloxacin plus rifampin when blood culture became negative, plus gentamicin. But gentamicin is usually used in only one daily dose. It is recommended to follow this instruction recommendation if you want to cure these infections. And now I can conclude that implant-related infections represent a major health problems. Diagnosis and treatment of these infections are still difficult and have a lack of an universal definition. To cure this infection, long-term antibiotic therapy combined with surgery and removal of the implant is usually necessary. Antibiotic treatment without surgery is not recommended. The antibiotic use should have bactericidal activity against surface adherent, slow-growing, and biofilm-producing bacteria. And as I can tell before, empiric antibiotic therapy depends on the local epidemiological situation and the information about colonization of patients with resistant bacteria. And we must know that the management of the implant-related infection should be based on interdisciplinary cooperation. Thank you very much.
Okay, so hello everybody. Thank you for the opportunity to be here today. As Professor Bejovic said, I come from ICU environment, and my task today is to talk about appropriate antimicrobial therapy of sepsis. As you may know, this is the area of many uncertainties, so I will go through the guidelines and try to talk about the correct approach, the approach that we consider today, and I look forward also to your thoughts and experiences at the end of my lecture. So this is my schedule for today. For the beginning, I will talk about new definition of sepsis and how it affects our antimicrobial treatment. Then I will talk about the time, choice, dosing and administration of the antimicrobials in sepsis, and to end with, I will mention de-escalation and the treatment duration. So let's start with the definitions. As you all know, this is the old definition of sepsis, when sepsis was considered mainly inflammatory disease, and before the year 2016, we said that sepsis was SIRS combined with infection. To have SIRS, you needed to fulfill two of these criteria. Severe sepsis was defined as sepsis with organ failure, and septic shock was defined as severe sepsis with hypertension after fluid resuscitation. There were two major problems with this definition. The first one was that the sepsis was considered only inflammatory disease. Today we know this is not the case, and we also know that as inflammatory response starts, anti-inflammatory response starts as well. And the other thing was this recommendation. If you look at it, it says that we should start antibiotic therapy in the first hour of recognition of septic shock and severe sepsis. And if you look at this definition, you might find yourself in a situation when you gave antibiotic to somebody who doesn't even have sepsis, because we know, for example, sepsis, according to this definition, could be also a very bad flu. So what the authors of this new definition wanted to gain was to stress that sepsis is really severe, life-threatening disease, and they also wanted to incorporate the new findings on pathophysiology of sepsis. So they said that sepsis is life-threatening organ dysfunction caused by a dysregulated host response to infection. And how to define organ dysfunction? Well, they said it's a change in total SOFA score more than 2. How many of you are familiar with SOFA score? Okay, that's a lot. Great. Well, do you think SOFA score is easy to calculate? No. Okay, so when you have a patient in our ED, we know the patient comes feeling sick, and then it takes time to get these parameters from the SOFA score, so we can say, okay, this one is having organ dysfunction. So I think it's nice, but I think it's quite complicated. And one more thing, SOFA was evaluated mainly in the ICU, and if we talk about patients at the ward, we know much less about the use of SOFA. And then septic shock was defined as sepsis with persisting hypotension requiring vasopressors to maintain mean arterial pressure above 65 millimeters and the serum lactate value of more than 2 millimoles per liter despite adequate volume resuscitation. Okay, so what could be done to recognize sepsis more easily than with SOFA? The authors came up with QSOFA. So QSOFA seemed very simple. There are only 2 variables, and the only thing you need to do today is to measure blood pressure, to ask the patient and see if he's contact, so to evaluate the mental status, and to measure the respiratory rate. And if we have more than 2 criteria of the QSOFA, and the patient who is having infection, and in this case, SIRS still helps, we're talking about the patient who needs to prompt antimicrobial and supportive therapy, the patient in which we must investigate organ dysfunction and begin monitoring of the vital signs as soon as possible.
Sorry,
Yes.
I'm not a medical doctor, I have no idea what SIRS is.
Okay, so it is systemic inflammatory response syndrome. I will just go back a little bit, and it is defined with these parameters, and you need to fulfill 2 or more criteria to fit. Okay? Okay. Can I continue? Okay, so we came to this. So why is this important? Firstly, I want you to understand that QSOFA is not sepsis. So it is only needed to show us which patient is really endangered and which patient might end in the ICU. And one more thing, we don't have gold standard diagnostic test for sepsis. This is not like a myocardial infarction when we can be pretty sure about our diagnosis. So still there is much concern on how to recognize sepsis. And for now, for the testing of QSOFA, it shows up to be not sensitive enough in the ED environment, so still there is much work to be done on this area. But however, please remember, if the patient has QSOFA more than 2, and we suspect that there is infection going on, this patient needs attention as soon as possible. Have you ever read these guidelines on sepsis treatment? Well, if you have, you know that they're huge, it takes few hours to go through them, and unfortunately they're based in many instances on very weak evidence. But to sum up, there are two main treatment strategies in sepsis. One is to fight immune response. That's the thing we were trying to do for the past few decades, and we were not successful. And the other thing is to fight bugs, and this is what we are talking about today. So you know that the antimicrobial treatment is the main stem of fight against bugs. We know that it eliminates microorganisms and removes the trigger for sepsis. It's fine to give antimicrobial treatment early. If we don't, the patient will progress to refractory septic shock. That microbial load really matters has been proved by some studies. Here is the study in patient with meningococcal disease, which showed that the patients in which bacterial burden was high, and bacterial burden was evaluated according to the DNA copies. So this patient had fulminant septicemia, as you can see. So they had a median of 20 million of copies. And on the other hand, patients with distinct meningitis or mild systemic meningococcal disease had a much lower level of DNA copies as well as LPS. And when they did logistic regression analysis, they also learned that perhaps from this we could predict the outcome of the disease and say whether the patient has a high level of DNA copies is probably going to die, and the mortality in this group was 100% when the copies were really high. And this is another study on this subject in which they wanted to evaluate whether data from DNA amplification test could be used to predict the severity of illness. These are data from the SeptiFast test, and they are not usually available, so these researchers got them from the manufacturer. And here they learned that in patients with a CP, this is the crossing point, less than 17.5, had more severe sepsis and septic shock cases, longer length of hospitalization, they were admitted to intensive care unit more oftenly, and they also had a little bit higher mortality rate. So the authors of this study recommended that this CP cycle should be reported as together with the results of SeptiFast test, and that could help us predict the severity of the disease. So let's go further to appropriate antimicrobial treatment. So what do we need to do? We need to initiate the therapy early. It must be active against causative microorganism. It has to have a good penetration to affected tissues. We need to have a bactericidal substance. Usually we administrate this therapy intravenously with loading dose when possible, and administration should be optimized according to PK and PD principles. So this is the recommendation on timing from Surviving Sepsis campaign, and still it states that antibiotic therapy should be started within 1 hour for both sepsis and septic shock as soon as possible. So how many of you are comfortable with this guideline? Do you think it's okay? No? Okay. Who doesn't like the guideline? Okay, why not?
Because it's not a very...
It's not an easy thing to do.
Sepsis, you have to give antibiotics in 1 hour.
Okay.
And it's a problem for diagnostic procedures that you have to give immediately antibiotics, and they don't have time to take cultures, and it can alter change the results of the cultures. You don't have cultures for definitive treatment.
Yeah, I agree a lot. I think we can be pretty sure, maybe in the case of septic shock, when the patient is really bad, hypotensive, admitted to ICU, and we're presuming he's having an infection, it's easier to give this therapy in 1 hour. In all the other instances, I think it's maybe a little bit too early. But let's say what the evidence has to say. So this is the study that was most cited everywhere. I'm sure you heard of it. It's a quite old study now, and they said, if you're late with antibiotics, their survival will decrease by 7.6% per hour, and it's really nice linear sort of rise. This study has been criticized by many. There were critics being retrospective, non-randomized. Then they included patients too slowly, about 30 patients per year. Nothing was said about source control, lactate value, vasopressors, and the overall mortality was really high, 56%. And what matters the most, the median time to antibiotic in hypotensive patients was 6 hours. Well, that's really a lot, and today I think none of us waits as long to give an antibiotic to hypotensive patients with infection. This was another more recent and very huge study. Again, after heavy statistical analysis, they managed to prove that the first 2 hours really matter. But the problem with this study was that it included patients who ended up in the ICU, and we know that this is the minority of the septic patients, and there are many septic patients in wards. And this is the latest study on the subject. Again, huge study, retrospective, including 35,000 patients. The minority of patients had septic shock. The half of the patients had severe sepsis, and about a third had sepsis. Mortality was 26% for septic shock, and of course less for severe sepsis and sepsis. Median time from ED registration to antibiotics was 2.1 hours, so it's quite a good time. And adjusted odds ratio for hospital mortality was 1.09 for each hour sepsis and slightly higher for septic shock. So an increase in absolute mortality with an hour's delay, in this case was for sepsis 0.3, which is not a lot, severe sepsis 0.4, and septic shock a little bit more, 1.8%. What this study didn't or couldn't explain was this. Because for the time of antibiotic therapy between 2 and 4 hours, the adjusted odds ratio for mortality were quite similar, as you can see. So they couldn't really interpret why is this like that. They concluded that, okay, for the most sick patients, for ICU patients, it's okay to give a therapy in an hour, but for the patients with sepsis who are not very sick, maybe 2 to 4 hours could also be okay. So not only timing, the adequacy of therapy is very much important. This is a very nice study showing the difference in mortality in patients who got appropriate antibiotic before ICU admission and those who got it afterwards. Here we can see that if patient got the antibiotic before ICU admission and median time to ICU admission was 5 hours, went through much better, the mortality was around 30%, and the patients who got to the ICU and then got appropriate therapy all had very high mortality, and it actually didn't differ much between 0 to 6 hours and more than 24 hours. One more data from the study, which is quite interesting, is that inadequate therapy was given in 44% of nosocomial sepsis, which is a lot, and also 23, so almost a quarter of community-acquired sepsis, and mostly when a patient had infections caused by gram-negatives. So prescribing appropriate therapy is still a great challenge. In this multivariate analysis, they also proved that prior ICU adequate antimicrobial therapy was a protective factor for survival. So what should we do? Empirically, we should cover gram-positives and gram-negatives, and we must account probable anatomic site of infection. We also must think of chronic comorbid diseases, especially severe immunosuppression. Then we must ask about social history of the patient, so has he been traveling, hospitalized in foreign countries, or in countries when they know that the resistance rate is high. Is the patient intravenous drug user? Was he recently hospitalized at our clinic? Did he receive any antibiotics in the last months? Was he colonized ever? Does he have any antibiotic devices? And of course, it's very good to know about local susceptibility patterns. So I will not go into details about this because there could be many schemes. This is an example from our quick antibiotic guide. So how do we prescribe antibiotics in some cases? For community-acquired sepsis, for example, then for hospital-acquired sepsis, where we must account bacteria like Pseudomonas aeruginosa, then in high-risk neutropenic patients, resistant pathogens come into play, Pseudomonas, or in some patients even Candida, and for patients on hemodialysis or indwelling catheters, these are the bacteria that should be covered. So this is one of our schemes that we use. How about multi-drug resistant pathogens? In Slovenia, we are lucky that we don't have many of these pathogens. When should we suspect of having a multi-drug resistant pathogen? So in these cases, there are patient features that should be considered, like comorbid illnesses, immunosuppression, type of infection, especially hospital-acquired, prior antibiotic treatment, previously documented colonization, and of course, local epidemiology. The big question is, should empiric antibiotic therapy cover MDR colonization? We do know that colonization markedly amplifies the risk of subsequent infection with a given MDR bacteria. But on the other hand, the positive predictive value of colonization of for bacteremia is low and can be as low as 4%. Actually, it is highest in urinary tract infections, so sepsis originating for the urinary tract. But for the other sepsis, the positive predictive value is quite lower. On the other hand, we also know that ESBL infections occur during the ICU stay in 10 to 20% of patients who are ESBL carriers. And empirical coverage really depends on the severity of the disease, source of infection, site of colonization, site of acquisition of infection, previous antimicrobial use, and indwelling devices. So it's not really easy decision to make. To help us, Goodman and the colleagues created this decision tree where we can see that patients at highest risks have received antibiotics in the prior months before hospitalization and were hospitalized for more than one night in an ESBL high-burden hospital and had a history of ESBL infection. So this is the tree that can help us with this decision. And in critically ill patients, this tree was incorporated into this quite complicated algorithm. But again, the same risk factors were stressed here. So having a patient with severe sepsis and septic shock, with community-acquired infection, there are some calculations we should do to see whether he is at high risk. On the other hand, if it is not community-acquired infection, the patient is having indwelling vascular device, the risk is high, and the same goes to the patients who received cephalosporins and quinolones lately. But as I said previously, quite complicated for the everyday use in the ED. Okay, we will talk about multi-drug or combination therapy for a while. So there are advantages of these therapies like increased spectrum of coverage, reduced risk of emergent resistance during therapy, synergistic effects, which has been historically described for the combination of beta-lactam and aminoglycoside and beta-lactam and fluoroquinolone, inhibition of bacterial toxin production like beta-lactam and clindamycin, and of course immune modulatory effects described in combination of beta-lactam and macrolide. But on the other hand, there are disadvantages like increased toxicity, higher cost, possible antagonism of this therapy, and also the selection of resistant strains. So what do the guidelines say about this? For the septic shock, they recommend at least 2 antibiotics of different antimicrobial classes aimed at the most likely pathogen, but this recommendation was weak due to the lack of evidence. However, most authorities recommend this approach. Combination therapy is not routinely recommended in bacteremia and sepsis, and even against for routine treatment of neutropenic sepsis, as evidence is this area is a little better. And they do recommend de-escalation within the first few days when we have a culture positive and also culture negative infections. Since there is a lack of evidence, this is only the best practice statement quality. This is maybe the best evidence of this. It's a very complicated meta-analysis who included a lot of sepsis datasets. These datasets had many patients included. And what they proved is that survival benefit was associated with combination therapy only in most severely ill patients. So these are patients with monotherapy risk of death more than 25%. But also they found worse survival if monotherapy risk of death was low. So if the patient was sick enough, there was no benefit of combination therapy. And this is one of the latest studies about combination of beta-lactam and macrolide in patients with pneumonia, which showed that the combination was effective only in patients with pneumococcal pneumonia with severe inflammatory response. In the other groups, there was really no difference comparing to monotherapy. Dosing is one very important part of appropriate antimicrobial treatment. If we give the right antibiotic at the wrong dose, it's not okay for the treatment of sepsis. So I'm sure Christina told you a lot about this yesterday. These are some dosing facts. Usually the patients, especially in critical care, are underdosed. The problem is a volume of distribution, which is increased in septic, critically ill patients. The renal clearance is augmented, and the lower exposure to antibiotics is present. So how can we improve this? By adding loading dose, calculating renal dose for individual patients, by using continuous or prolonged infusion, and by therapeutic drug monitoring. So this is one of the suggested approaches in patients who are septic and critically ill. So I'm not going to spend a lot of time on this. The doubling of the dose is recommended mainly in beta-lactams and in glycopeptides, and then for aminoglycosides, and the therapeutic drug monitoring for now recommended for aminoglycosides and fluoroquinolones. This is the example of the dosing in critical care. So here you can see the doses are maximal, so the highest we can give, especially for the loading dose. And when do we use prolonged diffusion or against intermittent administration? So the aim of this approach is to improve effectiveness of time-dependent antibiotics, so to attain the concentration above MSC for as long as possible between the dosing interval, but the evidence of this approach is mixed for now. For the real-world patients, for now they had better outcomes for carbapenems and piperacillin tazobactam than cephalosporins. This is one of the latest meta-analyses on this topic. They evaluated the anti-pseudomonas beta-lactams, and they found the difference using prolonged infusion. There was a 30% lower risk of death in comparison with short-term infusion. It was a huge meta-analysis including 22 randomized controlled trials, mostly ICU patients, but severe renal failure was excluded. And also they couldn't answer on questions about sepsis severity, causative agents, MDR bacteria, and so on. So what do we do in renal failure? The problem is that renal dose adjustments were determined in healthy subjects with stable chronic kidney disease, but the critically ill patient looks like this. So we have a lot of infusions, septic shock is distributive shock, so the volume of distribution is much higher. And then we have increased vascular permeability, hemodynamic instability, cardiomyopathy, low level of albumin, and very dynamic changes in renal function. So are these doses still suitable? Most people think don't. So what the experts came up with lately was to give a standard dose for the first 48 hours for antibiotics with wide safety margins, because they proved that up to 50% of patients have improvement of renal functions in the next 2 days. So this is the approach we use also in our intensive care unit. Only a word about the de-escalation, very important part of antibiotic stewardship, but applied in only 40 to 50% of patients. The problem is the lack of evidence, but on the other hand, the evidence does not suggest harm, even in sepsis, ventilator-associated pneumonia, and neutropenia, and we do need much more studies to support these strategies. However, the guidelines recommend daily assessment for de-escalation of antimicrobial therapy in patients with sepsis and septic shock. Duration of antibiotic therapy varies, but lately it has been shortened, and it is recommended that it should last 7 to 10 days for most serious infections which are not complicated but by foci of infection, or in cases we have bacteremia with staphylococcus aureus, fungal or resistant pathogens. In these cases, the therapy should last longer. And one thing we must not forget is source control, very important part of treating sepsis. Only antibiotics are not enough when we have a source that should be removed. So to conclude with, appropriate antimicrobial therapy of sepsis is early, especially in septic shock, but in patients with sepsis who seem stable, sometimes it is reasonable to wait an hour or so. Antimicrobial therapy should be active against target pathogens in vitro and applied at doses sufficient to achieve pharmacodynamic targets in vivo. We should de-escalate as soon as possible, and of course never forget source control. Unfortunately, I didn't give you the recipe for prescribing an antibiotics because the choice of antimicrobial is very much dependent on clinical picture, immune status of the patient, and epidemiological data. So thank you, and don't forget the Sepsis Day.
I'm a general surgeon from Jesenice. My lecture is based on up-to-date, the last version in February 2019. I have a disclosure, and this is okay. This is my English is much better after drinking a couple of beer in Irish pub. This black man is well known, and we hope we didn't saw each other, but he's copy-pasted from internet. Well, for introduction, I must tell you that among surgical patients, surgical site infections account for 38% of nosocomial infections. And CDC has developed criteria that define SSIs as infection related to an operative procedure that occurs at or near the surgical incision within 30 days or within 90 days if prosthetic material was implanted at the surgery. Clinical criteria, I begin with the last one. The surgeon makes the diagnosis of infection. The purulent exudate draining from a surgical site. A positive fluid culture obtained from a surgical site that was primarily closed. A surgical site that is reopened in the presence of at least one clinical sign of infection, no matter if the culture was positive or not cultured at all. And when we talk about wound classifications, we have 4 types of surgical wounds. The first one is clean wound. Clean wounds are uninfected operative wounds in which no inflammation is encountered and the wound is closed primarily. A viscus is not entered during the surgery, and the infection rate at those wounds is between 1.3 to 2.9%. The second is clean contaminated wound or wounds. These are operative wounds in which viscus is entered under controlled conditions and without unusual contamination. That surgical wounds are infected in 2.4 to 7.7%. The clean contaminated wounds are probably the most popular and most common surgical wounds. Contaminated wounds are open, fresh, accidental wounds, operations with major breaks in sterile technique, or gross spillage from a viscus. Wounds in which acute non-purulent inflammation was encountered also were included in this category. And these are the percentage for infections. Dirty wounds are all traumatic wounds with retained devitalized tissue, foreign bodies, fecal contamination, or wounds that involve existing clinical infection or perforated viscus. Dirty wounds are a problem, but they are not very common, or not very common in elective surgery. When we talk about microbiology, we must know that about 50% of all surgical site infections were due to microbial flora of the patient. After clean procedures, the flora is mainly derived from skin flora. That means that streptococcal, staphylococcal, and coagulase negative staphylococci are representatives for infection of clean procedures. In clean contaminated procedures, the predominant organisms include gram-negative rod enterococci in addition to skin flora. When the surgical procedure involves a viscus, the pathogens reflect the endogenous flora of the viscous or nervy mucosal surface. Such infections are typically polymicrobial. Exogenous source, 35% represents 35% of these exogenous sources are personal. 15% represents the environment. Nasopharyngeal, anaerobe, vaginal carriage of group A streptococci by OR personal is a very frequently described cause of surgical site infections outbreak. And not wonderful news for all who likes beautiful fingers and nails. Carriage of gram-negative organisms on the hands has been shown to be greater among surgical personnel with artificial nails. Indications for antimicrobial prophylaxis is justified for clean contaminated procedures and for some certain clean procedures where there are severe consequences of infection, even if infection is unlikely. Well, you should know that a very big problem is artificial joint infected with what kind of germ. And the disaster is for the patient. So the use of antimicrobial agents for dirty procedures or established infection is classified as treatment of presumed infection, not prophylaxis. Goals of the treatment: prevent SSI, prevent related morbidity and mortality, reduce the duration and costs of healthcare, cause minimal adverse drug effects, and antibiotics you use for surgical prophylaxis must have minimal adverse effect on the microbial flora of the patient and also microbial flora of the hospital. Antimicrobial agent should be active against the pathogens most likely contaminate the surgical site. Should be administered in an appropriate dose and time to ensure adequate serum and tissue concentrations during the period of potential contamination, and should be administered for the shortest effective period to minimize adverse effects, emergence of resistance, and short costs. Selection. The antibiotic you use for surgical site prophylaxis must be cheap. Safety should have a suitable pharmacokinetic profile and suitable antimicrobial activity. The cefazolin is drug of choice for many procedures. Has a desirable duration of action, reasonable safety, and low cost. It's active against all those germs listed below. Sometimes second-generation cephalosporins are in favor because the coverage against gram-negative bacteria is greater than in first generation or cefazolin. It's not likely that your patient who tells you that he has an allergy against penicillin is in generally allergic. Patients with history of penicillin intolerance manifesting as an uncomplicated skin rash may be treated with cephalosporin. Allergic cross-reactions between those two groups of antibiotics are infrequent. Cephalosporins should be avoided in patients with a history of IgE-mediated reactions to penicillin. This is type 1 allergic immediate reactions, you all know. Alternatives to cephalosporins are IV vancomycin, IV clindamycin. In some cases, if you use that agents, you should also use something that is active against gram-negative bacteria. There is no consensus in the health policies that we need a preoperative screening of Staph aureus colonization. There is no rule for routine use of vancomycin for any procedure. Nasal colonization with methicillin-resistant or methicillin-susceptible Staph aureus and preoperative prophylaxis with vancomycin was associated with an increased risk of postoperative surgical site infections. Vancomycin is acceptable when you have a cluster of surgical site infections due to MRSA or coagulase negative staphylococci at an institution. When you know that your patient is MRSA positive, and when you have a patient with a high risk for MRSA colonization in the absence of surveillance data. Patient with recent hospitalization, nursing home resident, patient on chronic treatment like patient on immunosuppressives or maybe patient on hemodialysis. If you use vancomycin for prevention of surgical site infection, maybe it is a good idea to use cefazolin together with vancomycin, because your patient can receive an MSSI surgical site infection which was not good covered with vancomycin, not well covered. Resistant organisms, we talk about beta-lactam resistant bacteria. Surgical prophylaxis for those patients must be individualized. When you decide to include coverage for such pathogens depends on many factors. The pathogen, the host, its antimicrobial susceptibility profile, the planned procedure, and the proximity of the likely reservoir, or the proximity to the incision site. Specific prophylaxis for a resistant gram-negative pathogen in a patient with past infection may not be necessary for clean cutaneous procedure. When you give antibiotics, you should give it venously. Choice of dose. Dose should be sufficient to achieve adequate serum and tissue drug levels for the interval during which the surgical site is open. For most adults, it's acceptable to dose antimicrobials based on standardized dose for safety, efficacy, and convenience. You should administer those drugs obese patients in higher dose. When we are talking about timing, antimicrobial therapy should be initiated within 60 minutes prior to surgical incision to optimize adequate drug tissue levels at the time of initial incision. The half-life of the antibiotic should be considered, and administration of vancomycin should begin 2 hours before surgical incision because of prolonged infusion times required for this drug. Repeat intraoperative dosing is warranted for procedures that exceeds 2 half-lives of the drug and for procedures in which there is excessive blood loss. Redosing is necessary when antimicrobial half-life is shortened, like in severe burns. Redosing is not warranted for patients in whom the antimicrobial half-life is prolonged, like it is in renal insufficiency. Duration of the prophylaxis. Repeat antimicrobial dosing following wound closure is not necessary and may increase the risk for development of antimicrobial resistance in the community and Clostridial difficile infection. There is no difference in the rate of surgical site infections with single dose compared with multiple dose regimens. For cases in which prophylaxis beyond the time of surgery is warranted, in general, the duration should be less than 24 hours. I prepared you some examples of surgical site regimens, prophylaxis regimens, and on the first slide we have 3 mostly clean surgical specialties. Traumatology and orthopedic surgery, as we see, the pathogens are almost the same. These are skin-derived microbials, and as we see here, for clean procedures without any implant in traumatology, you don't need prophylactic antibiotics. When we implant or remove some metal parts into your body, you need a cefazolin. When you are over 120 kilograms, you need additional 1 gram of cefazolin. The redose interval is almost the same in all 3 specialties. Cardiac surgery, this is also clean procedure, the same pathogens, but they are very fond using this second generation cephalosporin. Neurosurgery, it's okay. Well, abdominal surgery is another big problem. The clean procedure is here in yellow. Oh, sorry. The clean procedure is in yellow. The hernia repair is only clean procedure here. The cefazolin is okay. The others are clean contaminated. The upper intestines from mouth to ileocolic area, the germs are gram-positive cocci, gram-negative bacilli, and some Clostridia when we are talking about biliary surgery. The cefazolin is okay. If we have laparoscopic surgery or clean procedure laparoscopically, like gallbladder removal, you don't need antibiotics. If we are going beyond duodeno ileocolonic anastomosis or ileocolic passage, anaerobes are problem. So we use first or second generation cephalosporin, and we add a kind of antibiotic that is active against anaerobes. Metronidazole is maybe better than clindamycin. If we have obstructed small intestines, you should probably use metronidazole also. And well, we are in the very problematic region of colorectal surgery, the surgeons are usually prepare their patients with a mechanical bowel repair in Europe and also in the United States. But difference between this side and the other side of the Atlantic is that that Americans use also oral antibiotics to prepare the bowels before surgery. And they use a combination of neomycin and metronidazole. The preparation takes about 10 hours. They received about 3 doses of those antibiotics. Maybe this is a good idea. It's not, if you clean the bowels, you should also give the antibiotics into the bowel. I think that 3 times neomycin and metronidazole is not a big problem for environmental causes. These are also head and neck and gynecological and obstetric surgery are also mostly clean contaminated procedures. Maybe this is better than gynecological because they use mostly first or second generation with some metronidazole if you enter the mucosal surface. Well, I don't like to tell you more about gynecological surgery because they have many problems with recommended antibiotics, and you can use first or second generation almost for all. I don't know why this is a problem. This is a problem probably because of microbiological causes. I don't know. Well, and that's thanks God, it's all.
Now, when we think of multi-drug resistance, do you hear me?
Yes.
Okay. So when you think of multi-drug resistant gram-positive bacteria, what do you usually think of? It's penicillin-resistant strep pneumonia, it's methicillin-resistant Staph aureus, or vancomycin-resistant enterococci. So there are guidelines to address the MRSA infections, and there are also some documents from the ESCMID, but these are pretty much out of date. And I don't know, I'm not aware of any Infectious Diseases Society of America or ESCMID guidelines that would specifically address multi-drug resistant enterococci or multi-drug resistant strep pneumonia. So I decided to organize my talk to orient it on the MRSA case and then try to discuss some of the therapeutic possibilities around it, and then the second part will be on the VRE case. So this first patient with MRSA, this was a 36-year-old man. I borrowed this case from the literature, which is very nicely described in this paper in Antimicrobial Agents and Chemotherapy. So it was a 36-year-old man without any significant past medical history. He was admitted to burn unit after a motor vehicle accident with burns 28% of his body surface. On day 46 after his admission, he developed fever, and the blood cultures yielded MRSA with vancomycin MIC value of 1 microgram per ml, and the patient was started on vancomycin. The ultrasound of the heart did reveal a opacity of 0.8 by 0.5 vegetation on his aortic valve, and an infectious diseases consultant was called. Now, on day 7, his blood cultures remained positive. So this is the patient with MRSA, with vancomycin with MIC of 1. And on day 7, the blood cultures remained positive. The trough levels of vancomycin were within the wanted range. But this time, the MRSA cultivated from the blood showed this type of sensibility or sensitivity results. So the vancomycin MIC was 2 this time. And the MIC for daptomycin was also at the upper limit of the sensitivity range. Now the question in such a case now is, well, I thought this would be an interactive talk. Now, should we or would you continue with vancomycin in such a patient, or would you choose one of other therapeutic possibilities, maybe monotherapy with perhaps one of the newer antibiotics that have been with us for the past decade, or maybe perhaps a combination therapy. And since the guidelines, like I mentioned, are out of date, we cannot really rely on the guidelines in how to approach, how to treat such a patient. So I'll try to give you some scientific background for the choices that they made in this particular case. So if we talk first about mechanisms of daptomycin resistant in Staph aureus. So daptomycin resistance comes in practically 3 different flavors, so 3 different kinds for Staph aureus, for Enterococci, and for Viridans group Streptococci. The mechanisms of resistance are not the same. In daptomycin, the mechanisms are such that the cell membrane and the cell wall perturbations happen that result in daptomycin, the daptomycin binding is less, and the surface of the Staphylococcus gets more positively charged, which repels daptomycin, because daptomycin interacts with calcium, so we get this calcium daptomycin molecule, which is also positively charged. And if the Staph aureus is positively charged, then they repel each other. Daptomycin and the bacteria repel each other. And then again, what can be seen phenotypically in those strains that are resistant to daptomycin, pretty much similar as in Visa, that they develop this thick cell wall phenotype as opposed to the wild type of Staph aureus, which has a more thinner cell wall. Now, what are the genotypic correlates for those resistant patterns? They are, of course, different, but the most common and well-studied is the mutation that happens in this MIPR resistance gene, and it does not cause loss of function, but it causes gain in function. And the name of the game here is progressive accumulation of single nucleotide polymorphisms that happen during daptomycin exposure. And this happens in vitro, but it also was shown that this happens also in a clinical setting. So this gain in function mutation causes that the phosphatidylglycerol, which is part of the cell membrane, gets lysinated. And this is a positively charged molecule, and the bacteria flips out this molecule to the surface, and this is why the bacteria gets this positively charged on the surface and repel calcium daptomycin. And then what happens on the other side, when phosphatidylglycerol becomes lysinated, then we have a lack of phosphatidylglycerol, but this is necessary for the daptomycin to act, because daptomycin interacts in the membrane with PGs. So this is kind of a double effect of double resistant mechanisms. So in this particular case, this patient had an MRSA strain that was ceftaroline resistant. Now, even though this drug is relatively new, there are cases described with ceftaroline resistant strains isolated. And again, also the molecular basis for this resistance is well known, and of course it was shown that the mutations happen in the penicillin binding protein 2, a department which is the targeting site of the ceftaroline. But this particular patient, he was not exposed to ceftaroline, and then this question was triggered whether ceftaroline resistance can also evolve maybe just spontaneously, and most probably it does, because when they did those big screen of MRSA strains, even from before ceftaroline has been put on the market, they saw that there are some natural sequence variants that are intrinsically resistant to ceftaroline, and most probably this particular patient also had such a infection with such a strain. Now, is it common to get ceftaroline resistance? Most probably the answer is not, and this is the study that that shows this in a sophisticated way. Namely, in the laboratory they passed Staph aureus for 50 times, and they could not get a strain of Staph aureus that would have an increased MIC value. Now, what about this combination that was put on the bottom of the slide? The combining therapy in this case maybe with dapta and beta-lactam, because the daptomycin and beta-lactam synergy has been shown to be effective in Staph aureus and also in enterococci, and there is also some biological explanation why this combination might be plausible in a clinical practice. First, it was thought that maybe only because the beta-lactam sensitizes bacterial surface just by making it more or less positively charged. Or maybe it's the seesaw effect, which was also seen with this combination, namely when the daptomycin MICs go up, the Staph aureus produces, as a contra effect, produces or hyperproduces penicillin binding proteins, and we can see that with MIC for daptomycin going up, the MIC values for beta-lactam go down. But most probably, what they showed in the past few years, the synergy has to do something with which is penicillin binding protein 1 specific action. In this study, now the white bars represent those beta-lactams that preferentially bind to penicillin binding protein 1, and the dark one those that are not specific or that bind to penicillin binding protein 1, 2, 3, or 4. And what they showed is that when they mix daptomycin with penicillin binding proteins that target penicillin binding protein 1, which are like carbapenems or piptazo, that they reach the synergistic effect. So if these, what are these, whatever, are to the left, this means that bacterial burden was lowered, and this proves the synergistic effect. So it's not really the same if we put different beta-lactams in this dapto-beta-lactam combination. So if we choose this combination, we should go for the beta-lactams that preferentially bind to penicillin binding protein 1. Now, what are the clinical data on the ceftaroline use in patients with persistent MRSA bacteremia? There are data accumulating in the literature. This is a review of different studies. The biggest one is this one. So they've included 123 patients with persistent MRSA bacteremia. One quarter of them had endocarditis, and the clinical outcome was pretty much sanguine. So there was quite a nice response for ceftaroline used as salvage therapy in patients with persistent MRSA bacteremia. Now, this is an example of clinical data for the combination of daptomycin and ceftaroline. And in this case, they collected cases from different hospitals in US. So there were 26 cases, but 20 of those had MRSA, 10 had endocarditis, and the other 10 had other complicated Staph aureus syndromes. And in the end, they found out that the outcome was actually very good. 24 out of 25 patients survived, and those were all patients with persistent Staph aureus bacteremia. So after having been treated with first-line regimen for MRSA or for MSSA in some of those cases. So what they concluded is that ceftaroline offers dual benefit via synergy with both daptomycin, but also with some with some innate molecules that we have that are also negatively charged, which is also one of the possible mechanisms why, for example, flucloxacin, these are only in vitro data, why it works with MRSA. Now, what could be conclusions for this case, like a take-home message for difficult to treat MRSA cases? So we don't really have good data from randomized trials that would instruct us on how to deal with those patients. So we should always depend on the individual susceptibilities testing results in our particular patient, and maybe we should go and try other new antibiotics on the market, or maybe combined therapy. When thinking of combination therapy, there are good biological data to support combination of daptomycin and selected beta-lactams, but not really good data for combination of vancomycin and beta-lactams. Yes?
I would like to ask you a favor before you go further. To explain me again the mechanism of the synergy, because I didn't...
Of daptomycin and beta-lactam and ceftaroline? Yeah. Okay. So it's what the daptomycin does when it binds into the membrane. This is a positively charged molecule. Daptomycin in our serum binds together with calcium, and calcium gives daptomycin this positive charge. And what Staph aureus does is that when being in contact with daptomycin, that if it's a resistant strain, of course, then this mutation that happens in this resistant gene actually causes the phosphatidylglycerol, which is one of the main phospholipids in the membrane of the cell, becomes positively charged. And then the bacteria flips out that positively charged molecule in the membrane, so the membrane of the cell becomes positively charged. So it's positive now. And the calcium daptomycin is also positive. So you get it electrostatic repulsion. They repel each other.
This is in this way is Staph aureus resistant to dapto.
To daptomycin, yes.
How is working the dapto with ceftaroline?
Yes, but then when they try this in vitro, but we also have now in vivo clinical data that when they mix daptomycin and ceftaroline, then the daptomycin, the Staph aureus, when it's been exposed to daptomycin, hyperproduces penicillin-binding protein, and then this ceftaroline, but it's only the penicillin-binding protein 1, so it's not like flucloxacillin, which is a non-selective beta-lactam, and not like ceftriaxone neither, or cefotaxime. So it's ceftaroline that binds to that binding site and acts. And in this way, it helps the daptomycin to do its work. And the other mechanism is also that when you give the beta-lactam makes the bacteria less positively charged because it brings in the negative charge. So the bacteria is no longer that positively charged as it was before, only with daptomycin. And now this repulsion mechanism is lessened, is not so strong anymore. The ceftriaxone is no good. So we have biological proof for ceftaroline combination. That ceftaroline because of this penicillin binding 1 capacity.
So you combine ceftaroline with
daptomycin with ceftaroline. For this we have biological data, so in vitro data. And we also have, like I showed you, that study, and this is not the only study. So we have also clinical. These are small clinical studies, like you see, 20 patients. These are not 200 or 2,000 patients. So small clinical case reports and small clinical clusters or whatever, groups of patients that have shown in vivo, so in clinical practice, that this combination really works as salvage therapy. But it has been shown that the combination of vancomycin, for example, with beta-lactams does not have, neither in vitro nor in clinical studies, such a good outcome.
So actually you start with vancomycin, and in case of persistent positive blood cultures or refractory infection, then you can use this combination actually.
Yes, one possibility would be to use ceftaroline as a monotherapy. So the first choice is vancomycin or daptomycin. This is already in the guidelines. But the guidelines won't tell us about these new drugs that are also available. So we need to, when we have such a patient, I have never had such a patient. This is why I took one from the literature. So I suppose, yes, that you are much more experienced. I only read about those cases. So if you have such a patient, then you need to go and not just to look out through the guidelines, but unfortunately, we need to look for clinical cases and for a series of patients that had been treated this way. But with these particular combinations of daptoceftaroline, we can be quite comfortable with this combination because there's also this in vitro biological data that this combination should truly work.
And which dosage do you use? 6 milligrams? 10 or 8?
The dosages, yes.
8
And it's been one paper that came out last year about these dosages, and it was a retrospective study, but still they compared the 10 or less milligrams per kilogram per day or more than 9, and it came out that those patients who were given higher dosages had a better outcome. In this particular study, they also incorporated linezolid. This was then for enterococcal bacteremia. So most probably for bacteremia, the dosages should be higher. Yes, not as there are licensed in SMPC.
Is there data about vancomycin combinations?
The vancomycin, no, I haven't found such. I've just, last year, or maybe, I'm not sure whether it was last year or 2 years ago, I've listened to a talk on combination therapy for MRSA. It was an American professor who gave that talk. And then he had in a one row like first line agent, which would be like vancomycin, daptomycin, and then in the second would be like gentamicin, beta-lactams, I don't know, rifampin, whatever. And he calculated that there are 80 possible combinations. So we are not supposed to get those results, of course. But he was kind of supportive of giving such combinations in vivo, in clinical setting, that do have some biological background. And this is such a combination with this kind of background. So I'll continue with the second case. So this was a 45-year-old man with arterial hypertension, with acute lymphoblastic leukemia, who relapsed and actually needed a new cycle of chemotherapy. And this patient had a enterococcal bacteremia with Enterococcus faecium 3 months prior to this hospitalization. And at that time, so 3 months ago, he had been treated with daptomycin, 8 milligrams per kilogram, for 2 weeks. And now he returned again with fever. And his blood cultures this time again grew Enterococcus faecium, and he was put on daptomycin, a bit higher dosages than 3 months ago. But these are the susceptibilities of the Enterococcus faecium that was isolated from blood. So again, I've never had experience to treat such a patient. So multi-drug resistant enterococci. And then, again, different possibilities with combination therapy, with monotherapy, with different new antibiotics. Now, what is the mechanisms of daptomycin resistant in Enterococci? Similar, but not totally the same as in Staph aureus. So one mechanism preferentially seen in Enterococci faecium is the diversion mechanism. So this is kind of a mechanism where the enterococci, they divert the daptomycin away. This is the division septum of the bacteria, and this is where daptomycin should be. This is where it works. And these bacteria, the resistant bacteria, they somehow divert it away from his point of action. And this is the repulsion mechanism that resembles the one in Staph aureus. And this repulsion mechanism is mainly described in Enterococci fiscium, not fecalis, like the first one. So these are some in vitro data to support these, how should I call them, those mechanisms. So here we see Enterococci that is susceptible, and the majority of the accumulation of daptomycin is at the division septum, but this is totally different in a resistant strain. So the daptomycin binds away from the division septum. However, the quantity of the daptomycin that is bound to the cell is pretty much the same in a susceptible and in a resistant strain. And with this repulsion mechanism, what we see, this is a susceptible strain, that really in a resistant strain, there's really a reduction of daptomycin binding to the bacteria. And again, one possible combination also with supportive data in vitro, when these are enterococci in red, and the green marked with a green fluorescent is daptomycin. So these are just being exposed to daptomycin, but here being exposed to daptomycin and ampicillin. And we see this synergistic effect that truly daptomycin binds more when ampicillin is being added to the broth. And what they wanted to tell us in that paper is that it's not totally the same whether we have a resistant strain with, in both cases, the same MSC values of 16. So these are two resistant strains of Enterococci. However, they take a different molecular path to develop that resistance. And in this strain, this combination of dapto and ampicillin truly led to restoring daptomycin's bactericidal activity. So we see the lowering of the bacterial load, but this did not happen with this strain. So the MIC would be the same. So this would be the report that a clinician gets, the MIC value. But if the patient had an infection with such an organism, the combination would not work in this case. So this particular patient was put on the daptomycin-ampicillin combination because what they knew is that this mutation is the one that is most common in resistant E. fiscium. He was put on this combination of dapta and ampicillin. You can also see what dosages they used. However, the patient failed to clear his blood cultures. The ultrasound of the heart did not reveal any vegetations. So the tigecycline was added, and during the further course, during the following weeks, he did not clear his blood cultures, and they switched different treatment regimens, quinupristin, dalfopristin, and then they added ampicillin, and then they changed to ceftaroline rifampin, which is sort of homemade recipes because they had to do something, and they did not have a focus of infection. But finally, the ultrasound did show a focus of infection, and there was a small vegetation on his, I don't remember whether was it a mitral or aortic valve. But surgeons, because this particular patient, he appeared well because he was already afebrile, hemodynamically stable, but his blood cultures remained positive, and the surgeons refused to operate him, which was why the ID physicians or the microbiologists clinical microbiologists who were involved thought of trying and treat this patient with erytavancin, which is one of the new lipoglycopeptide antibiotics on the market with good in vitro efficacy against Enterococcus fiscium, also against those with VAN A and VAN B resistance to vancomycin. And this particular patient was given ritavancin, not in a monotherapy, but in a combination therapy. And they also finally also managed to persuade the surgeons to perform the surgery. And the patient survived and cleared his blood cultures. So what would be the take-home message with this VRE case? That there are cases of daptomycin non-susceptible enterococci appearing in the community or appearing in the literature for us so far, because I haven't had such a patient. I'm not sure why they call it daptomycin non-susceptible, but if I understand correctly, they use this term not resistant but non-susceptible, particularly for these enterococci. Maybe the microbiologists, you know why this is this terminological distinction. And maybe the combination of daptomycin and a beta-lactam, again, it's not all beta-lactams were created equal, so it's not really the same whether you put different beta-lactams in this combination. But for enterococci, the combination that proved effective in vitro was a combination with ampicillin, like I showed, but not with ceftriaxone. And again, with ceftaroline, did show that good synergistic effect, and that maybe a ritavancin may be something that might be of help in such a difficult combination, but most probably in a combination therapy, because again, what they showed in vitro milieu, that with exposure to ritavancin, mutations, so resistance does occur, 10 to minus 7, which is 1 in 10 million cells would become resistant when being exposed to ritavancin. And this I put in just to give you an idea how often an ID physician like I am encounter difficult to treat MRSA or difficult to treat enterococci, which is almost never. So maybe those who work in intensive care units, they do, but I do not work there. So I haven't had a patient with so heavy or so difficult to treat bugs. Thank you.
So we have finished with the gram-positive, and now we also have the problems with the gram-negatives. No, this is not the right one. Okay. So another group of bacteria, more problems, I guess. They're a bit more common than the gram-positive MDR bacteria. You all know that we are speaking about the multi-drug resistant bacteria when they are not susceptible to at least one agent in at least 3 antimicrobial categories. And we speak about extensively drug-resistant bacteria when they are not susceptible to all but 1 or 2 antimicrobial categories. Usually those antibiotics are colistin and tigecycline. And pan-drug-resistant bacteria are those who are not susceptible to all agents in all antimicrobial categories. If you look into the chart, you see the different antibiotic classes are put to different bacteria. The microbiologist informed me that not all antibiotics are tested with every bacteria, so it's sometimes difficult to say that the bacteria is really pan-drug resistant because it was not tested for all the drugs. So we have to say explicitly that they have to do another test, especially for the 4th generation of cephalosporins. You are familiar that in recent decades we have the emergency and spread of MDR and XDR enterobacteriaceae, and they are really high on the list of the public health problems. They are very common pathogens, so they can cause different type of community and hospital-acquired infections, and because of their antimicrobial resistance, they have a significant potential for the antibiotic use and also the outcome of the treatment. The treatment is really difficult because we have limited antimicrobials which are effective against those bacteria, and of course we don't have really good data about the efficacy of those antibiotics. So the paradigm that the specific drug is the drug of choice across most clinical situations no longer holds. You know that some drugs can be used in some clinical situations but are not effective in another clinical situation. So like gentamicin can be used for the treatment of urinary tract infections, but it's not good for the treatment of pulmonary infections because the concentrations in the lungs are much lower than in the urinary tract. So the therapy should be individualized. You have to know where is the source of the infection, is it a really severe infection or is it mild infection, what is the susceptibility of the bacteria, and what kind of patients you are dealing with. Randomized controlled trials are scarce in this field, so the majority of our data are from observational studies, which are very often retrospective cohort studies. There are also some case series and anecdotal reports. Because there are huge differences between different countries and different regions, we cannot say now we have all start with a different empirical treatment for some bacteria. So it is up to your country, up to your hospital when you will decide to change your empirical treatment because of the high prevalence of different multi-drug resistant bacteria. In the recent years, the Enterobacteriaceae are the most important MDR and XDR bacteria. You all know that the Pseudomonas and Acinetobacter are on the scene for a very long time, but they have lower potential of spreading, and they are not so prominent and problematic as Enterobacteriaceae right now. The specific mechanism of resistance in Enterobacteriaceae are production of ESBL, MC beta-lactamases, or carbapenemases. Beta-lactamases can be put into the four classes according to Ambler. In case class A, we find KPC and ESBL. In B, metallo-beta-lactamases like VIM and NDM. Class C is just MC, there is no carbapenemases. And in class D, we have oxacillinases. The most prominent is OXA48, as you know. Carbapenem resistant and carbapenem producing Enterobacteriaceae are not the same because sometimes carbapenemase producing bacteria are more sensitive to other antibiotic classes than are the carbapenem resistant bacteria, which are usually resistant to more antibiotic classes. They cause very often healthcare associated infections, but they can also be found in the community. And as I said, the treatment options are very limited. We are using the so-called second line agents like polymyxin, tigecycline, fosfomycin, and also aminoglycosides, which is good for some infections, but not for the others. And usually the outcome is worse, not just because of those second line agents, but because we don't start with the right empirical treatment at the beginning. This was the situation with KPC Klebsiella pneumoniae 6 years ago. So it was those red spots, and red color is indicated where the bacteria was. And the green area are those areas where there are other carbapenemases, but not KPC, and those were endemic regions. So I guess the situation now is even more severe, but I was not able to find any chart providing that. So what is the situation in Europe? We are looking about ESBL. There are huge differences from north to south, and those changes are approximately the same in the carbapenem resistance. The situation is not so severe, thankfully, but there are some regions in Europe when the incidence of carbapenem resistant Klebsiella pneumoniae is quite high. What are our treatment options for carbapenem-resistant gram-negative bacteria? We have colistin, we have aminoglycosides, we have fosfomycin for Enterobacteriaceae and Pseudomonas. We can sometimes use ampicillin with sulbactam for Acinetobacter when we are lucky, and we can have tigecycline for Acinetobacter and Enterobacteriaceae, but not for Pseudomonas. Here we can sometimes also use Estronam, but it depends then on the type of resistance, which other antibiotics can be used for the treatment of our patients. So we are relying and hoping for the newer drugs, which are on the horizon, and some are already in our hospitals. Here is the chart representing novel beta-lactam combination agents for MDR gram-negative bacteria. You see that the most promising for all bacteria is cefepime combined with a new inhibitor of beta-lactamases, zidebactam. So we can have a covering of most of our resistance problems, but in others we have quite a huge gaps with oxa and with Pseudomonas and Acinetobacter. Then we have another group of drugs which are not beta-lactam combinations. Here we have cefiderocol, which is also very promising. Even they're now reporting that some strains of Pseudomonas are not really sensitive to the drug. And there are already some problems with multidrug-resistant Acinetobacter. As you all know, cephalosporins are not usually active against Acinetobacter, so this is a novel siderophoric cephalosporin, but already some resistance is reported. Plazomycin is not effective against NDM strains, and eravacycline has some question marks about the oxa. Then usually you know that the most studies are done for the urinary tract infections and for the complicated intra-abdominal infections, but our patients don't choose to have just those infections. They are bacteremic, they have hospital-acquired pneumonia and other infections. So in ventilator-associated pneumonia is a huge gap because we don't really have a lot of antibiotics which are registered for the use. And here is some examples for which of these antibiotics could be used in the ventilator-associated pneumonia and in which bacteria. You see a lot of empty spaces. Ceftolozane tazobactam for now has a registration for the treatment of complicated urinary tract infections and intra-abdominal infections, and it's pending the registration for hospital-acquired pneumonia and VAP. Ceftazidime has that registration, as well as meropenem varborbactam is also without registration or outright for the VAP. Cefiderocol was put on the priority FDA list, but just for the intra-abdominal infections, not for the other infections. Usually we decide about the treatment according of how sick our patients are, and some scores can be really helpful with that. With carbapenem producing Enterobacteriaceae, increment score is usually used. It is a predictive score for mortality in patients with bloodstream infections due to carbapenemase producing Enterobacteriaceae. You put some points for different situations, like if the patient has severe sepsis or shocked presentation, it gets 5 points. PIT score is a score for the severity of bloodstream infections in the MDR-resistant bacteria. You get 4 points if the patient scores 6 or more points. Charles Comorbidity Index of 2 or more gets you 3 points. If the source of bloodstream infection is other than urinary or biliary tract, you get the 3 points. And inappropriate empirical or inappropriate early targeted therapy, also 2 points. According to that, they have calculated the mortality in those patients, and they have got 3 groups. In the low group, from 0 to 8 points, the mortality was around 80%. In the intermediate group, from 9 to 13 points, mortality was around 50%. And in the high group, the mortality was around 80%. So it is really, the mortality really gets up with the more severely sick patients. So according to this study, they have decided that those are two articles citing approximately the same studies. One is from Rodriguez-Bagno, and others are British recommendations for the treatment of the carbapenem-resistant Enterobacteriaceae. And in those patients with the increment CPE score more than 7 and isolate which are susceptible to beta-lactam, they decide for the double treatment with backbone with one of the beta-lactams and a combined drug from colistin, tigecycline, aminoglycoside, or fosfomycin. It depends where is the infection. When isolates are resistant to all beta-lactams, then the backbone becomes colistin, and a combined drug, tigecycline, aminoglycoside, or fosfomycin. It then again depends on where is the source of the infection and which drug, and which bacteria you have. When you have the isolates which are resistant to beta-lactams and colistin, then you just use the combination of any active drugs. And the majority suggestions and clinical evidence go to ceftazidime with avibactam plus aztreonam, or double therapy with ertapenem and meropenem. You can try to use investigational drugs. In vitro testing for synergy is very difficult to perform, so it is done just in some laboratories. In less sick patients with the score, increment CPE score with less than 8, you can treat patients with monotherapy. If you are not sure of the source, then the beta-lactams are the choice of the treatment. In urinary tract infections, you can start with aminoglycosides or colistin or fosfomycin. In intra-abdominal infections and in skin and soft tissue infection, tigecycline or colistin are preferable drugs of choice. So both studies conclude the combination therapy may be beneficial for high-risk patients. It is also depending on the source of the infection and the presence of the septic shock. And monotherapy may be enough for lower, so-called low-risk patients. But do we really have a good data that support that statements? Here are two articles published in the last couple of years, which are stating the opposite of the recommendations. The first study was the meta-analysis of the 22 studies. They pointed out that there is a huge bias in these studies, and you can see everything it pointed in a black has a possibility of a bias. And they were able to show that there is only benefit of the combination therapy in bloodstream infections. No such effect was seen in pneumonia and in other combined infections. So there is just a small benefit of combination therapy in bloodstream infections. So they have put together the summary of the study that there is no solid evidence exists for the combination therapy against Klebsiella pneumoniae multi-drug resistant infections, that the addition of carbapenems, tigecycline, or aminoglycosides to polymyxin in the treatment of carbapenem-resistant gram-negative bacteria cannot be recommended. The only randomized clinical studies in that time showed that no mortality benefit is for the rifampicin or fosfomycin in combination with colistin for Acinetobacter infections, and there is unnecessary use of carbapenems, which can fuel the epidemic of gram-negative resistant bacteria in endemic settings. And this is the study which was done as the prospective randomized control study. It is one of the few studies which was published in this field. The patients who were randomized had bacteremia, ventilator-associated pneumonia, hospital-acquired pneumonia, or UTI, caused by carbapenem-resistant gram-negative bacteria. In the first group, they received just colistin with the loading dose and then followed with the high doses of colistin. And the second group got colistin combined with meropenem given in prolonged infusion. The primary outcome was mortality and clinical instability 40 days after the randomization. They have included 46 patients. Majority were with pneumonia or bacteremia, and the predominant pathogen was Acinetobacter. and the clinical failure at day 14 occurred in 76% of patients, so it was really, really high. But there was no significant differences between the groups, so it was not. It was the same if they were treated with colistin or with the colistin and meropenem.
It was Acinetobacter.
Yeah, it was Acinetobacter. Yeah,
quite tricky.
Yeah, it is. Yeah, but also they have looked into the other bacteria which were less prominent, but there were also no changes in the.
Yeah, but it was too less. The others.
Yeah, but it is not even showing the difference. So in the beginning there was some difference, but at the end you can see that the curves are coming to this. So per protocol, you see that there is no difference. 20-day 8 mortality was the same. Even in the groups which got the wrong empirical treatment, the 42 days, 28 and 14 days mortality was approximately the same. And in the bloodstream infection, VAP, and hospital-acquired pneumonia, the differences were not so significant. If we go to the different analyses, as I said, the Acinetobacter was predominant. Enterobacteriaceae were less common, but still there is not really quite difference. In Pseudomonas, the number is really too small to speak about the efficiency. And the same is also true for the 28 and the 14 days mortality. So they have concluded that given the potential of carbapenem to promote the carbapenem resistant, they recommend against the routine use of carbapenems for the treatment of carbapenem resistant Acinetobacter baumannii infections. So what do we have for the treatment of those infections? It is against huge differences between the north and the south in Europe, and especially in the MDR is also the big differences in the both part of the Europe. We can use colistin. Colistin is much better when we use it in higher doses, and we have to always use it with the loading dose. It is the problem that the therapeutic index is very narrow, so it would be ideal to perform the therapeutic drug monitoring, which is not really possible in all hospitals, and we have to adjust it in the kidney failure. There were reports using even doses up to 30 million units per day in the treatment of Acinetobacter. In tigecycline, there are good results in the treatment of MDR Acinetobacter, especially with the higher doses, so with a loading dose of 200 milligrams and then followed by 100 milligrams per every 12 hours instead of 100 milligrams loading and then 50 milligrams every 12 hours. We have to keep in mind that the tigecycline is bacteriostatic, so it is not really ideal for the treatment of bacteremic patient, because the serum concentrations are quite low. I have mentioned that some strains of Acinetobacter are sensitive to sulbactam, so we can combine it with ampicillin, given in the intervals every 4 or 6 hours, and it should be decreased in patients with acute kidney failure, but not in the first 2 days. In the first 2 days, we give it in the full dose. Fosfomycin is mostly used for UTIs. It can be dosed in the really high concentrations, but it should be lowered in acute kidney failure. Combinations have shown that there are better survival, but data were on the retrospective studies. Newer data, as I have shown, didn't show the difference in the survival. Among new drugs, we have eravacycline, which is fluorocyclic antibiotic. It is approved for intra-abdominal infections, not for the urinary tract infections, and it has a broad spectrum of activity against a variety of gram-positives and gram-negative bacteria, including very resistant strains. So we are just ending with Pseudomonas. The differences in sensitivity are not as huge as with Acinetobacter in Europe, but still here is more east to west than north to south. And MDR Pseudomonas is approximately, distribution is the same. Even there are some hotspots also in the northern regions of Europe. Ceftolozane tazobactam can be used in some strains of carbapenem-resistant Pseudomonas, but not in Vim strains. So if you have a situation which is present in Slovenia, where you have a lot of Vim-positive Pseudomonas, you cannot use ceftolozane, and you can also not use ceftazidime with avibactam. The drug is currently registered for UTI and intra-abdominal infections. Dose adjustment is needed in acute kidney failure, and the proposed dosage for the use in VAP and HAP is 3 grams every 8 hours, not 1.5 grams every 8 hours. Ceftazidime avibactam has higher indications, including HAP and VAP. Dosing is shown, and the dose should be adjusted. The majority of Pseudomonas is sensitive to colistin. There are just some cases where there is a resistance to colistin. So this is the backbone for the treatment of MDR Pseudomonas. Phosphomycin is usually used in combination, and it can be the dose can be increased up to 24 grams. So what do we know about combination therapy? If we conclude for Klebsiella MDR, we have low quality of evidence. It was shown that there is some decreased mortality in immunocompromised and severely ill. For Acinetobacter, we have moderate quality of evidence that there is no need for combination therapy. In stable patient is no infector mortality. For Pseudomonas, the data is very positive, and there is no difference in the mortality according to the recent studies. But still, because those bacteria, when causing the sepsis, have very high mortality rate with monotherapy, sometimes we have to still think about the combination of therapy, especially with those really, really sick with a high increment carbapenem score. Even the quality of data is low, but it might include some. We have to perhaps wait for some other studies. So in the era of increasing antimicrobial resistance, we have very limited options for the treatment. We are using so-called second-class drugs, which are revived now, and perhaps with new data, we can prescribe those drugs better. It is already known in colistin that in the history it was, or in the the dosage was too low, so, and there was not given the loading dose. There are very limited data from the studies. We have mostly case reports and retrospective studies. But we have to keep in mind that we have to know where the infection starts. So to do the source control, we have to deal with the severity of the disease and the patient characteristic when we decide about the individual approach about the treatment. We can use specific mortality scores, which can help us a bit about decision which therapy, and perhaps sometimes about the combination. Best drug, it's not the best drug in every situation, so we have to also evaluate that. And combination is proven efficacy only in very high-risk patients, but with low quality data and weak recommendations, and we can safely use monotherapy in low-risk infections. Thank you very much.